Assalamu alaikum. First of all, I would like to thank the organizers of this symposium from Shaukat Khanum for inviting me and having me participate. It really is obviously some will be what we have known for a while. So anyway, welcome to this journey, and we will talk about where I have been and where we are going in diagnosing mesothelioma. So as you know, the journey begins with the family group. This is all my family going on dilemma or the differential diagnosis of benign and malignant lesions, both in epithelioid and sarcomatoid lesions. Then how do we establish mesothelial lineage? Meaning what are the diagnostic immunohistochemical markers or molecular markers that we use? What are the benign and malignant markers that are helpful in this differential diagnosis? And lastly, a few words about mesothelioma in situ, because that is a relatively newly described lesion and we are understanding more and more about it. And then finally, dissection. Now, this is a really important piece of information from clinical because the setting is totally different. You know, this is not the history that you would expect. Medical history included smoking, coronary artery disease, and hypertension. Also remember that the history of asbestos exposure is really not important in the pathologic diagnosis and tissue side of the aortic specimen. And as you can see from this picture, there is a marked mesothelial proliferation. And then the question obviously becomes, what is this? Here on this next picture, there are papillary features with surface proliferation. Within the cores, there are blood vessels as well as some mild chronic inflammatory cells, which can often be present, and it doesn't help you in the differential. What does help you a little bit is the fact that there is a lot of proliferation. So that's one feature of this lesion here. Here at higher power, you appreciate that the nucleoli are prominent in these mesothelial cells. And there are free-floating mesothelial cells, maybe some small clusters in there, as well as those with fibrovascular cores. And here again, at higher power, you can appreciate that the cells are somewhat larger than the usual mesothelial gland cells you would see, and there may even be an occasionally binucleated cell like here and here. So then I sent you a series of questions, which I hope that you have reviewed in preparation for this talk. So the first question was that to work up the findings illustrated in the figures, which one of the following should be included? So remember, you only have to say one of these following. Do you obtain deeper sections? Do you obtain a history of asbestos exposure? Submit the entire specimen for microscopic examination? Or submit formalin-fixed tissue for electron microscopy? So let's see, what did I think? I think that the entire specimen needed to be submitted. Why are the other ones wrong? So deeper sections really are not needed because there is plenty of lesion in these pictures that I sent you. We only get deeper sections if it's a small biopsy and you think that you haven't cut deep enough into the block that you want to do, you want to see more tissue. Way of determining mesothelial origin was by EM, but in many years now, and I have presented in this symposium before on this topic. So I'm hoping that at least some of this will be new to you, the information, but obviously some will be what we have known for a while. So anyway, welcome to this journey, and we will talk about where I have been and where we are going in diagnosing mesothelioma. So as you know, the journey begins with the family group markers that we use. What are the benign and malignant markers? Cytologic diagnosis of mesothelioma, and what of the above will be applicable to cytology as well. So let's begin with the first case. This was a 77-year-old male who presented with sudden onset of chest pain. He was found to have an aortic dissection. Now, this is a really important piece of information from clinical because the setting is totally different. You know, this is not the history that you would expect in a mesothelioma. So remember that the clinical history. I would like to thank the organizers of this symposium from Shaukat Khanum hoping that at least some of this will be new to you, the information, but obviously some will be what we have known for a while. So anyway, welcome to this journey, and we will talk about where I have been and where we are going in diagnosing mesothelioma. So as you know, the journey begins with a family group. This is all my family going on a trip, and I will tell you the story of the trip as we go along. So what I'm going to talk about today are a series both in epithelioid and sarcomatoid lesions. Then how do we establish mesothelial lineage? Meaning what are the diagnostic immunohistochemical markers or molecular markers that we benign and malignant markers that are helpful in this differential diagnosis. And lastly, a few words about mesothelioma in situ, because that is a relatively newly described lesion and newly we are understanding more and more about it. And then finally, cytologic diagnosis of mesothelioma and what of the is totally different. This is not the history that you would expect in a mesothelioma. So remember that the clinical history is very important when you're making the diagnosis. So to continue, he was on Plavix. He needed to be stop his anticoagulation, so they allowed him a week for the drug to clear. His past medical history included smoking, coronary artery disease, and hypertension. Also remember that the history of asbestos exposure is really not important. There is a marked mesothelial proliferation, and then the question obviously becomes, what is this? Here on this next picture, there are papillary features with surface proliferation. Within the cores, there are blood vessels as well as some mild chronic inflammatory cells, which can often be present, and it doesn't help you in the differential. What does help you a little bit is the fact that there is a lot of proliferation. So that's one feature of this lesion here. Here at higher power, you appreciate that the nucleoli are prominent in these endothelial gland cells you would see, and there may even be an occasionally binucleated cell like here and here. You have to say one of these follies. Do you obtain deeper sections? Do you obtain a history of asbestos exposure? Submit. We only get deeper sections if it's a small biopsy. Electron microscopy, maybe 20, 30 years ago, that would have been the right thing to do, because at that time the best way of determining mesothelial origin was it's because you want to make sure that the lesion or whatever the tissue is that shows that mesothelial proliferation is entirely submitted to find any areas of invasion into the pre-existing tissue, because that would be the only thing that would make so or carcinoma marker, as well as MOC31 is negative. So with this panel, what is your interpretation? This establishes the diagnosis of mesothelioma. Mesothelioma markers and 2 carcinoma markers are enough to establish the lineage. So in this case, consistent with it, and no carcinoma markers are needed. Actually, there is some more recent literature now that shows that even 2 markers, one panel of stains would be most likely to establish a diagnosis of benign versus malignant. So now this is important to know, that what actually tells you benign malignant, right? So HEG1, BAP1, keratin AE1, AE3, or Merlin, CK56, and CEA for differentiating between benign and malignant. So why are the other markers? Mesothelial as well as epithelial proliferations will be keratin positive. Benign malignant, but P53 overexpression or mutational or abnormal expression that may indicate mutation in P53 is not very reliable and not a very good way of making that difference now in this day and age. So D is the right answer. All right. So then I'm going to continue and through this presentation illustrate all these. malignant, and I'll show you examples of that. Keratin is just shows you the general nature of this tissue. It doesn't tell you anything about whether it's benign or malignant. Remember, both benign and malignant mesothelial as well as epithelial proliferations will be keratin positive. Merlin is a benign malignant marker, but CK56 is not. That is a mesothelial marker, except for squamous, and CEA is a carcinoma marker. Desmond is really not helpful in benign malignant. A long time ago, it was used as part of a panel, but not anymore. NTAP is benign malignant, but P53 overexpression or mutational or abnormal expression that may presentation illustrate all these markers and features to you. So here are other sections that when we submitted the rest of the specimen, at the top left is aorta. You can appreciate its flavic history, and there was time with all of this reactive mesothelial proliferation to occur. There are some lymphocytes in the background, but that doesn't help you one way or the other, as well as the macrophages that are present, because those can be present both in benign or malignant mesothelial proliferations. At higher power, there is a sort of uniformity to it, but I think just H&E high power is usually not enough to differentiate benign malignant. In this case, I think it's the overall history, the findings, the lack of invasion, which is enough to say that this diagnosis is mesothelial hyperplasia and not a few other cases to illustrate different aspects of mesothelial proliferation. So this next case is that of an atrial appendage that had been ligated incidentally to or secondary to a cardiac procedure that was being done. And so I see a lot of atrial appendages because I do thoracic pathology, and in that, as they do scopic or thoracoscopic procedures, they go in through the atrial appendage, and so then as they pull their scopes out or their instruments out, they have to ligate it, otherwise you can get blood clots in it. So in this case, at low power, this is myocardium, and on the surface is a mesothelial proliferation, which is forming tubules in some areas, in contrast to the previous case in which there were solid sheets of cells. And here on higher power, these tubular structures are embedded within connective tissue, and the myocardium on the right side is not involved. So to establish mesothelial lineage and evaluate for invasion, this is a calretinin. Very nicely that these cells are mesothelial, strongly calretinin positive, and they're not invading into the muscle at all. On the right side shows you WT1 staining, which is nuclear. So, the location of the stain is very important in interpretation, especially in these mesothelial markers, because cytoplasmic WT1, as shown here in the muscle underneath, is non-specific staining, is not what you're looking for. In addition, see how the endothelial cells show cytoplasmic staining. That also is non-specific, that is a staining we see all the time, but does not indicate mesothelial. For it to be mesothelial, you have to see nuclear staining as you see here. So another atrial appendage, which has this incidental finding of mesothelial hyperplasia or an adenomatoid tumor. So if it looks like a tumor, like here in which it's a nodule, you would call it an adenomatoid tumor. If it is a surface proliferation, like here up on the upper side here and on the lower side, where you have this sort of little bit of papillary proliferation, you really would not call it a tumor, but I think either mesothelial papillary hyperplasia would be an appropriate to and work up for it, and when it, like in this case, when it's an incidental finding, that you would not need to do any stains at all. Although this bottom picture does look kind of atypical. These cells are prominent and forming little papillary cores or micropapillary projections without any fibrovascular core. You might start thinking that, oh, this is a little bit worrisome. Same thing on up here, because just because there are so many papillary projections on the surface. You may be thinking about it, but it is an incidental finding, and I don't think that you need to waste any resources or money on working that up. I would be quite comfortable on an incidental finding like that to say, all right, it is a little tough to make this diagnosis, but I'm quite confident that that is benign, so I'm going to continue on my journey here in the river. So this next case now is a patient who's being treated for multiple myeloma and develops ascites. So ascites by itself is actually quite a significant piece of history, because a patient with unexplained either ascites or unilateral pleural effusion is a very typical presentation for mesothelioma. And you have to take that really seriously and consider what is going on here. So incidental findings like in those atrial appendages, when there is no effusion, no symptoms, is highly unlikely to be malignant, whereas in a patient with ascites, if there was no other reason for it, would raise your sort of threshold for working up the case. Now, how does the multiple myeloma cause ascites? I am not sure how that is related, but the therapy for it, maybe this patient's therapy was cardiotoxic, or the patient has too much fluids being given as part of the therapy. I really don't know any more details. But what was taken out, they went in and the fat in the middle almost looks like fat necrosis, I would think. But then all of these sort of septae are rather cellular, and I'll show it to you at high power. Here's another field, very similar looking cells or infiltrates in the septae between the lobules of the fat. So what are these cells? Again, some of this, you see the surface mesothelium here, and then this proliferation. And on this right lower side, here is the surface proliferation of mesothelial cells, and underneath it is an infiltrate of chronic inflammatory or mononuclear cells, some of which may be macrophages. For mesothelioma, and you would want to either prove or disprove that. So the first thing I would do is a keratin. So the keratin tells you where the mesothelial cells are. That's the best use, I think, of a keratin, and you could use any of the keratins. I personally like CAM 5.2 for mesothelial cells, but A1, A3 works very well as well. So here it shows you that all of those interlobular sort of septa along have this mesothelial proliferation. The problem becomes is somewhere here when you start seeing some of the cells within the fat here, and then at the bottom right here. So you have to be careful to see what is going on. Here at higher power, all the cells are very strongly positive. Most of them are limited to the edge of the fat. I think maybe a few here, not quite, but sort of concerning. So I thought that this, with that clinical background and the fact that the patient probably has some other reason, reactive mesothelial proliferation in a background inflammation. On follow-up, this patient did really well and was continued to have their treatment for multiple myeloma, and really did not develop any mesothelial, any concern for a mesothelioma in this case. So the diagnosis was mesothelial hyperplasia. So now if you feel like my son has realized that we've hit this rock, my daughters really have not, and I'm in the back here and not really certain what is going on. So we have hit a rock here for deciding benign and malignant lesions in a mesothelium, in mesothelial. So we will talk about that. So this nodule, the next case, I think illustrates a real pitfall. The history is very important again. This is a nodule that is associated with an umbilical hernia, and that by itself gives you a clue that this is going to be benign, because these nodules have been very well described with hernias, specifically umbilical hernias. They can be quite large, up to 2.5 centimeters. So, that's a substantial size. I have actually been burnt, not in this particular case, but in a subsequent case when we got only a needle biopsy. And the needle biopsy looked very similar to this. Now, in retrospect, I can say, yes, I've learned from that case. But the needle biopsy looked very similar to this. The history was different. It didn't say that this was associated with hernia. The history said that there was a large pelvic mass. And they did this needle biopsy, and these cells are mesothelial. So I thought that that was a mesothelioma because the pelvic mass, I thought, was the mesothelioma primarily in the lower abdomen, and maybe there were some diffuse lesions elsewhere. So that patient actually then went on to have that pelvic mass excised. Well, when the surgeon went in, she thought that there was no lesion on the peritoneum, and multiple frozen sections did not show any lesions in the peritoneum. There was this little nodule, which was what I'm showing you here, similar to this one. And then that large pelvic mass just turned out to be a leiomyoma. So beware stories when your clinical history is not very good or doesn't fit. What you should be thinking of is that you have to think of both the clinical history and the morphology and your IHC stains and other things that you will use to work up these cases. Because otherwise you will make a mistake, just like I did on that needle biopsy. So here, let me illustrate this. So what are the features of benign here? One is that it is very well circumscribed. You look at the edge here at low power as well as at high power. There is fibrous tissue, but it sort of ends right there. There are some fibrous septae between it, which is also very characteristic. And this sort of uniform pale cytoplasm, very uniform cells with a very low nuclear cytoplasmic ratio, in which the nuclei are small, uniformly distributed, is a very characteristic appearance in these mesothelial nodules. And at high power, there really are no mitoses, but you can't really go on mitosis since mitotic figures can be very infrequently in mesotheliomas as well. So here you see this uniform sort of clearing of foamy cytoplasm and blood vessels scattered all the way through in a uniform distribution. So the blood vessels are equidistant from each other, which is also a very good sign of benign. In malignancy, the blood vessels are haphazard. Some areas may not have many blood vessels and others may have more. Also, there is no necrosis. So necrosis generally is a sign of malignancy. So both invasion and necrosis are not present here. And on staining, all the markers will be positive. So here is a calretinin stain, which actually nicely illustrates the fact that mesothelial cells have darker nuclei and paler, less brown staining of the cytoplasm, which is very characteristic. When you get non-specific calretinin staining in epithelial cells, it is generally only a small amount of it that is staining, amount of the lesion or tumor, and it is mostly cytoplasmic. So when you get only cytoplasmic staining, you should be thinking that that is an epithelial lesion rather than a mesothelial. The mesothelial lesion, not all the cells stain the same way. So but you should be able to find a significant number of cells in which the nuclei are darker than the cytoplasm. So that is a very helpful feature of calretinin staining that you will find. Okay, so now that we are really being tipped over into the water by the lesions that I'm showing you, I am going to move on to yet another case which is very concerning. So now this is a pericardial window done for chronic effusion. So it has all the features that I've been telling you about, right? To have a chronic effusion, whether exactly what was going on in the pleura. So that would be the first thing to find out when you have a case like this, in which the pericardium or the pericardial lymphatic, at the bottom here is an artery, that's likely a vein, and then this is a lymphatic right next to it. So in this lymphatic, there is a cluster of cells which look like they're invading or at least coming through partly through the wall and into the lumen. So any cluster of epithelioid cells in a lymphatic or a vein is very concerning for malignancy. But you can have an unknown primary and be working that out. So with a finding like this, you would first want to say, well, what are these cells? And then what is going on in this patient? So let's see. Did the markers, both the carcinoma and or epithelial and mesothelial markers, D240 shows very nice membranous staining. So that is the localization. A blood vessel wall. And with D240, you would think that this is a lymphatic because lymphatic endothelium stains for D240. Actually, that's how D240 they found to be positive in mesothelial cells was incidental. The research was being done on pleura for something else, so looking at vessels, and they found incidentally that the mesothelial cells are positive. And then here is a very nice crisp staining for WT1, showing you nuclear staining of this cluster of cells. And then again, as I showed you before, notice that the blood vessel at the bottom, the endothelial cells will also stain. But that's a and I don't know at the time whether I had any of the benign malignant markers, because they have been only around for the last few years, not very long. But based on the clinical information, as well as a lack of a tumor anywhere else, this patient's effusion was due to renal failure, and there was really no evidence of any mesothelial tumor. So I call that mesothelial cells in transit. So what are mesothelial cells like this? To compare, this is another case in which a lymph node biopsy was done in a patient with a large pelvic lower abdominal mass. And I think I understand this lesion much better now that I have seen more of these, and then we have done a multi-center study that I will share with you. So in this picture, what you should be able to recognize is that this is a lymph node with benign lymphoid cells here. And then in the sinuses, there is this mark here, and we'll come to that in a minute. In the background, there is some pigment within the lymph node. Here, maybe here some more, but that really, and in between here, that really doesn't tell you that much as to what this lesion is. So you do have to do stains. So here are the stains that we did, starting with keratin, shows you all of this proliferation of mesothelial cells in all the sinuses or sinusoidal distribution. Calretin shows you the classic staining with dark nuclei. You can appreciate that even at low power, that the nuclei are darker, the cytoplasm is less dark. And then WT1 shows you nuclear staining. So based on these stains, you can say that yes, there is a mesothelial infiltrate in a lymph node. And look at how extensive this is. This is not a mesothelial rest like we are used to seeing, little sort of gland-like structures which you can see in the abdomen, but these are really a lot of proliferation. And I think this is another case that I learned a lot from, because this first case that I saw originally came to us with just a needle biopsy of a lymph node. The outside pathologist had called it malignant, had called it a mesothelioma, and then I looked at it and I also called it a mesothelioma. But then when they went in, there was no tumor at all. The patient had ascites and had, I'm not so sure, I don't remember exactly what else, but there was definitely ascites due to a gynecologic issue. So what now? Cases like these are what will dump you into the water. So you have to be very careful and be thoughtful about what you're making a diagnosis of. But I think the practice of pathology is such that we will all make some mistakes. What you want is that the mistakes should be few, and as you gain more experience, you should be making fewer of them. And then each of those mistakes should be a new one. You learn from your old mistakes and don't make that one again. So I've already now illustrated two cases in which the first one was, I showed you before, and the nodular lesion associated with an umbilical hernia, and then now this one, which is in a lymph node. So what did we do after this one? This is a relatively recent case from last year. And then, so we did a multi-center study. I presented this case at a conference and asked for people to see if they had seen similar cases. We also went back and looked at some of our cases with ascites and lymph node biopsies to see how many of them we could find them. So we now actually have more than 7 cases aggregated, but the first group of patients that we analyzed were 7 cases of lymph nodes with mesothelial cells. The average age was 39 years. There were 3 abdominal and 4 thoracic. So that means that any case in which you have increased cavitary pressure, whether it be from here in March at your SCAP meeting, and we are in the process of writing it up, and we have collected more cases. And here is another mesothelial cells. So both in benign and malignant conditions, you can have macrophages mixed in with the mesothelial cells, because the presence of macrophages doesn't tell you benign or malignant. So here again, here's a WT1, shows you how much infiltrate is present in these lymph nodes. So what we think is happening is that these mesothelial cells in lymph nodes, with the distribution in the interlobular septa, but there's nuclear features, meaning they are benign-looking features. The immunophenotype is mesothelial. And then the clinical context, we need to see, well, what is going on? The clinical context in all of these patients was increased pressure, increased cavitary pressure. So we think that the mesothelial cells get pushed in through the preformed stomata that are present in these surfaces that connect to the lymphatic vessels. So when the pressure rises, mesothelial cells become hyperplastic, and then they can be pushed in through those holes into the lymphatics. So that's a normal where the normal lymphatic drainage would go. This also kind of ties in with that case of the pericardium I showed you a little bit earlier, in which the patient had pericardial effusion and had mesothelial cells in that lymphatic. Same principle, I think. I don't have a lymph node to go in that case, but these cases illustrate that you can have reactive mesothelial cells lodged in lymph nodes. So you may have an ascites or fusion or even a mass lesion, which is, if it's big enough, can cause enough distension in the lymphatics to facilitate mesothelial displacement. A few studies, I did a literature search, and what we found was that this phenomenon has been described before. It's not a new phenomenon. Several years ago, a few cases of this have been described, and they proposed that the inflammatory states, including pruritus, pericarditis, and chylous effusions, as well as post-surgery, may cause this displacement. So knowing about this phenomenon, I think, is really important, because then you will avoid that misdiagnosis. Okay, so we've talked about several benign situations in which, for example, if it's an incidentally found mesothelial lesion, or if you have a reason for the mesothelial cells to be pushed into lymphatics and lymph nodes, then you should think that this is benign. So this clinical setting kind of gives you a lifeline or a rope to hang yourself by, or to pull yourself up by, not hanging, to pull yourself up by. And so as you can see, we are all deep in the water. My daughter is starting to get a hang of the boat. And then hopefully, well, I'm still here to talk to you about it, and I'm still happy my kids are all okay. So we survived it. Don't worry about that. But this is sort of illustrating the journey through the mesothelial conundrum to show you all the things that can happen or go wrong. Okay, so next I'm going to talk about how to establish mesothelial lineage. These are the markers, and I have shown you pretty much all of them except for CK56, which is a cytoplasmic marker, as you would expect. And then HEG1 is a new mesothelial marker that has been is now starting to become more available, but it has been shown to be very sensitive as well as specific for mesothelial lineage. But I don't have it. This was first developed in Japan, and so they have more experience with it. And then there are a few centers in the US that are starting to use it. I'm not so sure worldwide whether people have adopted it or not, but maybe eventually we will, so that you can do fewer markers the patterns. So I'm comfortable using them. And I don't think I have ever so far had the need to do a HEG1, but I could always send it out for that marker if I need to. And then the carcinoma marker that really is best in this differential is Claudin-4. And I think I've talked about this to this audience before. What you're looking for is this membranous staining in epithelial cells. So this is a carcinoma control that we use, and it shows you this sort of almost dot-like staining in the membrane, because this Claudin is one of a family, Claudin-4 is one of a family of junctional proteins. Notice this background dot-like staining. This is actually negative. This portion of it is non-specific, and I'm going to show you a couple more examples of this. So not to call these dots positive, rather the membranous, sort of granular membranous staining is what's really positive. So that's a carcinoma marker. So just to give you a little bit more, I know you may have all used these markers. We've talked about WT1 being nuclear, showing it in blood vessels, and then skeletal muscle and stains non-specifically. So those are pitfalls you have to be careful of. To only look for nuclear staining. So some of the tumors may stain weakly depending on your conditions or how well it's fixed. And obviously, malignant tumors may or may not express it or may not express it as strongly as benign tissue does. So weak staining, as long as it's nuclear, is still considered positive. D240 is an excellent mesothelial marker because there are very few other things that are positive. Here it is showing you membranous staining, where it comes together. You can have more stronger, otherwise you can have only towards the basal layer staining and not in the middle. Sometimes I've seen luminal staining. So the patterns are kind of different. As long as it's membranous, that's positive enough. Calretinine here is very strong, and that I've seen sometimes happens is that the cells are so strong. But this picture I wanted to show you to illustrate that the normal fat is calretinine positive. So not to use that, not to be misled by the fat staining. Okay, so now I'm going to transition into benign malignant markers. And these are really the four that I have some experience with. So BAP1 and MTAP. So BAP1 was the first of these markers that came about, maybe 10 years ago or so. And it was first described in melanoma, especially in the germline mutation families. But now we know that those patients that have germline mutation will loss of BAP1 or mutations of BAP1 that lead to loss of IHC staining. So it's a very good marker, very clean, easy to use. And I'm going to show you some examples of that. And then we'll talk about this as we go along. All right. So here is a pleural biopsy, shows you mesothelial proliferation. Here are some lymphocytes in the background. When you're looking for BAP1 loss, which is pathognomonic of malignancy, you must make sure that the inbuilt control is working, which are all these lymphocytes and stromal cells. Not 100% of them, but many of them should be staining positive. So once that is positive, you can see, in this case, clearly see that the nuclear BAP1 expression is lost. And so that by itself tells you that this is malignant. So far, in all these years that we have been using BAP1, not a single case of a benign lesion has shown a BAP1 loss. So we are very fortunate, and every time you say, oh, always, you turn out to have something, show up that proves you wrong. But so far, we can say that BAP1 loss equals malignancy in a mesothelial setting. There are other tumors that lose BAP1. So once you've ruled those out, those are melanoma, a subset of melanomas, not all of them, a small subset of melanomas lose BAP1. Also, a very small subset of renal tumors can lose BAP1. And then there are a couple of others. I think there is a sarcoma, some rare ones. But those are easy to rule out in patients when you're thinking of a pleural-based or a peritoneal-based tumor and nothing in the visceral or in the skin. And the other markers are helpful. Once you have ruled out those other differential diagnoses, you can also say that this is mesothelial. Okay. MTAP now is different than that. So MTAP loss, the similarity is that when you have loss by IHC, MTAP also signifies malignancy. But MTAP loss is more in the cytoplasm. The nucleus sometimes is also lost, but not always. But the cytoplasmic loss, both in epithelioid and sarcomatoid mesothelioma, implies malignancy. So MTAP, though, is adjacent to CDKN2A. When that is mutated or lost, MTAP is lost secondarily. So always malignant, but does not signify that it is mesothelioma, because there are many, many tumors that will lose MTAP together with CDKN2A or P16. So just like homozygous P16 deletion by fish implies malignancy, MTAP loss implies malignancy, but doesn't tell you that it's mesothelioma. 5-HMC is a marker that's very and these tumors, but I don't think that I'm going to talk much more about it because it's not very widely used. Merlin is more recently described. It is the protein product of NF2. Originally, it was described and said that maybe about 39-40% of tumors have NF2 mutations, so you would expect that many to be lost. But there's a relatively recent publication that says up to 50% of has preserved Merlin. And then when you have loss, both the cytoplasmic and the membraneless loss occurs in this epithelioid lesion, and here in this lesion, I appreciate that this is the tumor cells, and here are the tumor cells that Merlin is lost. So Merlin, again, is a very good marker for malignancy because it has also not been described in any benign lesion to be lost. However, the problem is that you can't use Merlin in cytology as well, because this recent study from 2025 compared cytology cell blocks with tissue samples of the same tumor, and they found that there was only 50% concordance between the tissue and the cell block. And they think that part of it is because maybe the cells are difficult to identify, or they are discohesive. It's difficult to say. In some cases, you can tell that there is Merlin loss, but in others, you could not. So you have to be careful. Up until now, all the markers that I've talked about, both the lineage markers and the benign malignant markers, can be equally well used in cytology. And I'm going to illustrate that to you in a minute. Okay. So before I move on to other things, I'm going to talk about just a couple more things about pitfalls. We've talked about the histology patterns. That's really important. You can have a mass and yet not be malignant, but be a nodular proliferation of mesothelial cells, for example. The non-specific staining I've been showing you all along. Here I want to just emphasize that for BAP1, only the nuclear loss is diagnostic. In this case, notice that the nuclei are brown, are not brown, they're blue, so that there is nuclear loss, but that the cytoplasm is brown. So this cytoplasmic staining is non-specific and should not deter you from calling this case as BAP1 loss. For MTAP, it's the other way around. MTAP should be lost in the cytoplasm. It may be lost in the nucleus as well, or it may be retained. It's not as significant. So for MTAP, you want to look for cytoplasmic loss. For BAP1, you want to look for nuclear loss. Okay, Claudin, I've already mentioned to you that membranous staining is indicative of an epithelial lesion, whereas this dot-like staining is a pitfall, is negative. So far, Claudin is an excellent marker. However, there have been anecdotally 2 mesothelial cases, one described by Dr. Chugh and one by Dr. Schulte in Wisconsin. Of mesotheliomas will be negative, and 99.5% or something, a very high number of carcinomas are positive. So it's a great marker. MOC31 we don't use as much anymore. It used to be a very good marker, thought to be a good marker for carcinoma, but here is otherwise a mesothelioma that is showing you focal staining. So MOC31 will have about 20-30% overlap with closer to being rescued here. Okay, so the last few slides, I'm going to talk about this case. This was a 72-year-old male who was excellent health otherwise. Who developed what he thought was bronchitis or pneumonia. The symptoms did not improve. He still was losing weight. He was short of breath. And then the CT demonstrated that there was a thickening of the pleura. I think if this was seen at our case, we would not have stopped with just fluid cytology, because fluid cytology may be negative, but this appearance is so classic for mesothelioma that it is unilateral. There is a diffuse pleural thickening, and the other side is okay. And he has weight loss, shortness of breath, that to wait 3 months to wait for the nodular pleural thickening, I think is not appropriate. At this time, his cough was persisted. He was continuing to lose weight. And although there was a history of asbestos exposure, I don't think that really helps you one way or the other. He underwent a core needle biopsy. So this biopsy shows you a haphazard proliferation of spindle cells, some of which are somewhat large or crushed together. One thing I want you to see is that there are really no blood vessels in here, even though it is just a needle biopsy. If you look around, there are areas where there is less cellularity and maybe some more cellularity in atypia, but all the way it's very paucivascular. So the very few cells, blood vessels should make you think, oh, this is not a good sign, because those are signs of malignancy, to have few blood vessels or haphazardly arranged blood vessels. Then when you go high power, some of the nuclei are really small. If they were all like this, I would say this was benign. But then when you start seeing some larger nuclei like these, that should raise your threshold for malignancy, because that is a feature. So atypia in some areas and not others. And then almost starting to have these, what's called bland necrosis. You're starting to lose nuclei in here. That is very characteristic of malignancy. Again, some atypia, although not a very well-preserved cell. So the differential diagnosis is between reactive and sarcomatoid mesothelioma in this case, so I'm going to talk about that. If this was a mass lesion, you would also have differential that are the other masses, but that's not something I'm going to, not relevant in this case, because it wouldn't present with this diffuse infiltrate, but you should think about all of these other lesions when it's a solitary mass. So this patient, and now the lesion has progressed, is also infiltrating into the septa. And what would you do? So you would do the same thing as you do in the epithelioid lesions. First, you have to establish mesothelial lineage in which the mesothelial markers may be lost. So keratin is kind of focal. So this one, I was lucky that is staining. Cytoplasmic staining also, which is considered positive. This is positive enough in a spindle cell lesion. And here also very granular looking staining. So that is D240 and is helpful. HEG1, which is a new marker, is also positive in these lesions. This is not my slide, but Dr. Hiroshima's slide, in which shows you this HEG1 is a cytoplasmic stain and is positive in both epithelioid and sarcomatoid mesotheliomas. May not express GATA1, GATA3. So also, if your differential is from breast, that's not a good marker to use. But if your differential is from lung spindle cell carcinoma, GATA3, if it is positive, will favor mesothelioma. But if it is negative, you would think carcinoma, but not all the time. So that's the pitfall in GATA3. And when it really looks sarcomatoid, I think the GATA3 expression is even stronger. And so it's very nicely illustrated here. And there are some recent studies showing you what percentages can be positive or negative. And we should look at those. Okay. Invasion in spindle cell lesions is very helpful because it goes into the fat. Here, we'll show you that it is malignant. So what are in the morphology, you can look at the atypia, the lack of blood vessels. Then we look at invasion. Then we can do IHC for benign versus malignant. You can do FISH for P16, and then some molecular testing. So then what else? Here is invasion. Again, the tumor cells are invading into the fat. This is that bland necrosis that I was talking about, that I had shown you earlier, in which there is not much of an inflammation, no inflammation at all, but then just these areas that become necrotic. Keratin is very helpful to demonstrate the invasion into the fat here of these spindle cells. And here on H&E, this lesion is invading into the lung parenchyma. So any invasion into a pre-existing tissue, like fat, lung, is malignant. This necrosis, I don't know if bland necrosis is a good word for it, but anyway, the tumor cells themselves are necrotic inside. This is not surface necrosis, which can occur in any lesion that's protruding into the pleura, but this is within the tumor itself. And again, you may have some little bit of fibrin associated with that necrosis, usually not hemorrhagic, but I have seen hemorrhage as well. So contrast this to granulation tissue and pleuritis. At the surface on the left side is fibrin, then all of this granulation tissue growing into it, very uniform vascularity and highly vascular, in contrast to mesothelioma. Again, mitoses may be present, or well, actually there are a lot of mitoses present in granulation tissue, because that is how this proliferation is extending to organize the fibrin. As it becomes more fibrotic, the uniform parallel vascularity is a nice benign feature. As it gets more and more dense fibrosis, you may lose that vascularity, but the uniform distribution of the nuclei is helpful. And then the fibers tend to be more parallel, especially within plaques. MTAP loss, this is a picture I had shown you before, also is helpful. It's a very good benign malignant marker, because MTAP is lost in it's almost like 90% of sarcomatoid mesotheliomas, together with CDKN2A loss or homozygous deletion, is very high in sarcomatoid mesotheliomas as compared to epithelioid. So this is really helpful. BAP1 loss is rare in sarcomatoid mesotheliomas. Only about 10% are reported to lose it. And here is one case in which it shows you these nuclei that are in between in the sarcomatoid mesothelioma that has lost BAP1. But you can't really depend on this as well. MTAP is a better benign malignant marker in this setting. And here at high power to show you that BAP1 loss in a sarcomatoid mesothelioma. Merlin, this is a biphasic mesothelioma in which the sarcomatoid component has also lost Merlin. So is illustrated here. So here is the epithelioid component on the left of this picture, and the sarcomatoid component here in the middle on this side. So when those are lost, it's very helpful in saying that this is a biphasic. All right, so what have we said so far? CDKN2A, if there's a homozygous deletion, it's malignant. MTAP deleted is malignant, BAP1 deleted, same thing. And NF2 mutation, if it occurs, is also malignant and likely a mesothelioma, because NF2 mutations occur very infrequently, other than in malignant MPNST. This chart illustrates very nicely how to go about, if you have a pleural lesion, how to go through the various stains and differential diagnoses. And this is available as a PDF from Archives of Pathology in Lab Medicine if you look for this. And I think it's a great article also to have. Sorry to say that for myself. I mean, but there are 26 of us authors in it. It's a huge study or a huge group that publishes guidelines for this pathologic diagnosis. And a lot of what I have said is in that one. So now we have been rescued. We have a lot of tools at our disposal, and we are going to come out of it. And I'm going to just go over quickly with the questions that I've submitted with this case, and then which of the biopsy or which of this lineage panel would be established mesothelial lineage. And this by now you should be able to answer that you D240, GATA3, and Claudin-4. So Claudin for epithelial. This in a spindle cell lesion, GATA3 is very helpful. I would not use it for an epithelioid lesion. So remember, GATA3 is only helpful in spindle cell mesothelioma or sarcomatoid mesothelioma. And the others are a mixture of things. So which of the statements is correct? That with the asbestos exposure, it's mesothelioma, you know that that's not right. And that history of asbestos exposure should not be used. And that is what is the correct answer. The clinical picture I already showed you with that diffuse mesothelial, the diffuse thickening of the pleura is very, very suggestive. And the weight loss is extremely suggestive of a malignancy. Now, the cytology was negative. This tells you that cytology in sarcomatoid lesions is not helpful because spindle cells don't shed into the space. If you were to do an FNA, it would be different. You may be able to get the spindle cells, but in effusion cytology, it would not be helpful. And then, which is the diagnosis of malignancy? So, BAP1 loss of nuclear staining. Okay. What? Oh, sorry. BAP1 loss of nuclear staining would be helpful in only about 10% of it. MTAP loss would be much more helpful and much more likely to establish the diagnosis. This was a trick question. I think it's most likely. BAP1 loss would, of course, if it was present, but it isn't present that often. So MTAP loss is the best. All right, so now we are back onto the boat and going along our way. And so I'm going to end with a couple of things. Mesothelioma in situ, I've mentioned briefly. What we have shown now is that you can see patients. It was first described only in the pleura, but we have now, it has also been described now in the peritoneum. And here is a case in a patient that presented with recurrent ascites. And how do you make a diagnosis? It's very bland. Remember that original case I showed you of the atrial appendage with this papillary proliferation? This one with the history of recurrent ascites is what will make you do the stains. You can do either BAP1 or MTAP or Merlin or 5-HNC, any of the benign malignant markers. If they are lost, it's malignant. So then if there is no invasion, you call it mesothelioma in situ. This patient 1 year later developed invasion, and this is a picture from that biopsy. Again, it shows you how bland these mesothelial cells can be. What should raise your suspicion is the history, either recurrent unilateral pleural effusion or recurrent ascites. You should work up for these patients and call it mesothelioma in situ. So on cytology, all of the things that I've talked about are applicable, except for, as we said, and I showed you. So calretinin, WT1, D240, all the mesothelial markers are very helpful, including Claudin-4. So the benign malignant markers are helpful. The molecular studies can all be done. You can do FISH for homozygous deletion. And here is a case showing you BAP1 retained on cytology. And here is a case showing you BAP1 lost. Note that the background cells show very nice internal control. Here is an MTAP retained. What you have to be careful of is that there are lots of macrophages in the background. And when the MTAP is lost, so benign malignant markers are very well used in cytology. And so that is what I have for you for today. And so thank you for listening. And I will be available in person for questions and answers after this. And I hope to see you all then when I do in October. Thank you.
Dr. Alia, can you hear me, please?
Ji, Assalamu alaikum. How are you?
Alhamdulillah. Thank you so much for joining us. I know it's quite late over there, and you
It
had
is. It's okay.
for us. Thank you for that excellent lecture. It was really useful. Just before I start the questions, I want to add that the last time you came and you had such a wonderful lecture on mesotheliomas and you recommended BAP1, and we started adding BAP1 in our immunohistochemical panel. And since then, we have confidently diagnosed a lot of mesotheliomas, and it's really alarming to see how much mesothelioma we do see here per year. So I'll start with question myself that although BAP1 is a very useful marker, but still, because the setup we work in, we hardly get any excision biopsies. It's usually either small biopsies or pleural fluids, sometimes peritoneal fluids. And the problem with the fluids is if the BAP1 is lost, it's really helpful. But if it is intact, and they keep on sending us pleural fluids again and again. For some reason, they can't do biopsy or something. And we keep on writing atypical mesothelial proliferation in those cases. So what do you recommend in such cases? What should we do? Because we hardly have any history available or radiological findings available. And that's all we can do, basically.
Yes. So, what I would say, first of all, is you could try bringing MTAP online because between the two of them, BAP1 and MTAP, you will make a diagnosis in almost 90% of cases. So, that's a very good marker to add on to it. The next one would be Merlin, but I don't know what the availability is. Secondly, you also have to look at if it is a unilateral effusion, pleural effusion, and how what is the cellularity. If it's very cellular lesion, you can suggest that it's mesothelioma. I guess the question also is uh, that are they doing these taps for diagnosis or are they doing it because this is just so much fluid is collecting that they're doing it to relieve the symptoms somewhat? Because I'm not so sure what the treatment would be. Immunotherapy is really has made a difference, and if that is available and for your patients, then the diagnosis must be made. And I would say at least at the larger centers, someplace one should be able to do MTAP.
Uh, the 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 reason why they keep on doing the taps in such advanced cases is because the clinician is very suspicious of an epithelial malignancy,
Yes.
because at that stage it's usually that much advanced that they are suspecting an epithelial malignancy, and we keep on telling them that it's an atypical mesothelioma, and they
Yeah.
want to just sort of
I
rule.
see. So, on if on radiology it really looks malignant, then you can say most consistent with mesothelioma.
Right. Yes, that makes sense.
So, right. So a mass, a plural, radiology should be really helpful.
Yes. And another thing is we have started doing Claudin 4 as well, because we didn't had that before.
Yes.
And initially I thought it was a very good marker. Honestly, it was really helpful. But lately,
Sorry, I can't hear you anymore. Hello?
and two epithelial markers.
Sorry, you cut out there. I didn't get the last few sentences.
So I was saying that we usually do two mesothelial markers and two epithelial markers for the provision. And sometimes, unfortunately, we do not get two mesothelial markers positive. It is usually either WT1 positive, and we still call it mesothelioma if the BAP1 is intact. So any advice on that?
So nuclear WT1 is actually a very good marker for mesothelioma because there are very few other tumors that are WT1 positive in an adult. So if you're thinking of, say, the desmoplastic small round blue cell tumor is positive, or Wilms tumor, all of those are really rare to have in an adult. So I think even with just WT1 positivity, you could say it's mesothelioma. The other markers, I mean, CK5-6 is very helpful if it's not squamous. And then when all the, or if you say Claudin-4 is negative, then that's a really good sign that it's going to be a mesothelioma. I don't hear you again.
I hope we can see you in person next year.
I would love that, but you have to give me a little bit more notice. I'm going to be there in November, but I couldn't come now. Thanks, but thank you for having me join on Zoom.
All right. Thank you.
All right. Thank you. Khuda Hafiz.
Yes.
I need to prepare for postgraduate and undergraduate training. As Marie just mentioned, I'm training program director for that and Royal College examiner. And various opportunities are given to me when I go around. And in fact, during COVID time, I did some session for Pakistan too, online. And I was doing mostly training online. It started at that time. Online training is now the fashion. But when COVID started and people were not going to department and training was affected, I think one of those centers where I started this training, and now um, there are two courses or three courses that are running from Bristol, which are not only for whole UK, but for the, I think, in that sense, you can say international, because students from multiple countries they participated joining that. And one is that particularly for ST1, histopathologist, when they join in, I do a very basic course. So but if we people happening there as well, which is again, who the region is involved in that. So what I prefer, what I wanted to say is that, that we do a lot of interactive sessions. And this helps me to gauge the level of the participant, and then I can pitch my talk on that. So today I put mixed cases. Some cases maybe you don't see that often, but you may come across and you always have a differential diagnosis. So I will give you some clues how to reach on progress in those cases. But many of these cases are very simple, day-to-day cases. So there's no catch or anything. And people sometimes are very hesitant to commit. So when you commit, only then you can either gain confidence that you are right, or if you made a mistake, then you learn from that. So commitment is very important. Sometimes people find difficult when they have got 2 or 3 questions answered in their mind, and when one of these is correct, they say, oh yeah, this was in my differential diagnosis, I'm okay. But now you are committing the answer, then you know which one is right and which one is wrong. So you will learn from that. I've got many cases today, but I know the time is short, only 90 minutes. So I think I have already consumed 5 minutes in the question. So if you interact quickly, then we may be able to see many cases. Otherwise, I want to stop when my time is over. Is that okay? Yeah. So case number one. Which is very low power view. You can see that this is a relatively circumscribed lesion. Might look like maybe slightly cystic or may have okay, and shows a little bit some artillery configuration too. Next one. Yeah, and this is a higher magnification of the same. Next please. What time are you finishing? What time are you finishing? So 12 o'clock. Okay. So what's your diagnosis? The voting starts now. Already 5 people have voted on that. But mostly the differential diagnosis over here for papillary lesion, intraductal papilloma. Papilloma, as you know, is also intraductal papilloma, which has got sclerosis and no papillary structures identified. Then solid papillary carcinoma, as you can see, that was mostly solid areas. And incystic papillary carcinoma on the basis of, because it was very circumscribed over there. But if you think it is something different, which I have not put it in there, then you can take an option for E as well. And then we can discuss how many people said E. Yeah? Okay, so how many people have voted so far? 18, that's great. Excellent. Next one. So you see wide variety of people are taking from this. And I'm not expecting that you can make a diagnosis of SNE. I mean, you know that it's not a real life thing. First of all, there are only few snapshots over here. And secondly, you usually do some immunos and make a diagnosis. But just to take the initial impression, you know, all these things comes into differential diagnosis. And I would like to know those who have said E, what is in their mind which I haven't put it in the differential over here. Any volunteer who thought there might be different diagnosis? Don't hesitate, because you know that one thing I always say to my student, that if you are right, then you will get confidence. But if you are wrong, not only you will be learning it, but the whole class will be learning through you. Yeah. So who said E? And if you were comfortable, and if you're comfortable, if you can mention, you're probably right. Yeah. So I give you a little more confidence over here. Any suggestion? No? Okay, we'll come to that later on. But just remember that only 6%, maybe about 2 people who thought E, yeah? But mostly thought something different. Okay, just go to the next. Case number 2. Now this is on the right hand side with the low magnification over there. Lesion which is quite superficial. And I think it's probably from the nipple. And you can see some the scent from main ducts over there. And then this is a high magnification where you can see this nested pattern over there. And this is a further high magnification of the same lesion. Next one. So what is your diagnosis? Is it adenoid cystic carcinoma? Is it adenomyopithelioma? Is it solid papillary carcinoma or other? You did very quickly. Go back. No, just forward. Just stop there. No, I think polling closed. So just go back one more. I think slide moves very quickly, but anyway, at least we have got some just over here. Again, some people thought this may be other something else. Would somebody like to share over here? What do you think that other might be, which is not in the list here? Okay, no problem. We'll discuss that further. Yeah. Go next. Now, can we go? Yeah, next slide. Now you saw that in this particular thing, when you have to identify that the cells mostly are pale in color, relatively, yeah. And there are only areas where you can see small tubular circle or more darker cells. Yeah, these are the darker ones, and there are a few more over here and there. And if you do the immuno, next one, then you will see that most of these cells, which are paler in color, they are basically myopithelial cells. Yeah, and only small less for those small tubular structures which you saw over there, they are positive for luminal epithelial cell. But you might say that it is CK56 and it should be myopithelial cell, isn't it? Interestingly, in this particular diagnosis, although WHO group says that this is a unique for this particular diagnosis to have CK56 expressed in luminal cells and not myopithelial cells. But again, they are wrong in that book. So I'll show you the example where you can see that CK56 in the similar differential diagnosis. Yeah. So any thought by looking at that immuno, and then you can see over here, these are myopithelial cells. So by looking at immuno, you may probably now know the diagnosis. Any volunteer? It will be very interesting if you participate in that and you will enjoy it, I'm telling you. Even if you are wrong, you will learn something out of it. If you are right, then you will get more confidence. And Dr. Mushtaq will give you some brownie points over here. Okay, something say? What is your diagnosis? Shall I put fingers on? No, I think it's very important. Otherwise, it will be very boring. I said you will start sleeping soon. Yeah. So if you just participate into that, it will be great. Doesn't matter if it's right or wrong, but it will generate a discussion, and that's what the purpose is. I'm not here just to give you another lecture. And you will hear lecture during the conference so much. The workshop is basically practical thing. Sorry? Diploma. Yeah, that's maybe one thing. Okay. Anything else? Dr. Diploma. Okay, what else? Okay, just two things. First of all, in ductal adenoma, we quite often see central area of sclerosis development because it is a sclerosis ductal papilloma, which wasn't there. Secondly, there you see much more fibular structure. I wish I had brought one. I didn't thought that, so I got on my laptop. I can share you ductal adenoma too. When you see very open lumina, over here you are seeing penile cells. These are all myopithelial cells, and ductal lumina are compressed and only visible when you are doing this immunostaining or you look hard. Because if you are very familiar with the breast every day, you are looking at it, you know, quite often my colleagues come and show me cases and they say, oh, it is inside the village, you have to just make an answer quickly because I don't have time. And 99% of the time I say, oh, I can see my cells, this is where it is. So with experience, you don't need immuno to identify. When you see these paler cells, you know, there's no staining artifact, obviously, but if you've got a consistent staining in your department, then when you see paler cells, then you can say that these are mostly myopithelial cells over here. And this is adenomyopithelioma. And this adenomyopithelioma, I say it's not a simple and easy diagnosis. Yeah? It is not a simple and easy diagnosis. I find myself difficult. And quite often, even if I make diagnosis, I get somebody else to confirm that as well. But here, what you are seeing is that this is, and this shows very different patterns. We can show tubular structures quite often, like you see in adenospermous. This is a biphasic tumor, basically. Yeah? Let's go to the next slide. So basically, these are biphasic tumors to start with. Then all the differential diagnosis comes into that where you see epithelial myopithelial differentiation. Yeah. Like adenomyocystic carcinoma, lymphoma, you can put into that, and even as I said, low-grade adenospermous carcinoma, where although that is not a biphasic, but you see myopithelial layers there. And it shows various architectural patterns. and quite often it shows a papillary-like structure. As I said, it can be tubular, it can be papillary, and quite often it shows lobulated. And I'll show you slide in a minute, where it can look like exposed ductal papilloma, where you see central area of sclerosis with tubular pattern, and at the periphery you see the lobules. I'll show you the slide in a minute. Yeah. So there's a multilobulated pattern with central sclerotic areas, and you can see sometimes satellite nodules as well. And on immunohistochemistry, you can confirm that this is a dual agent regional and myophysical cells. And what they say is that it's a unique, and I have quoted this exactly from the WHO book, that this is a unique that CK56 will be positive in luminal cell. But I'll show you all its differential diagnosis, but I've come across and seen CK56 positivity. So it is not unique in that sense. So don't put too much weight on CK56. Most of the time, because there are some ER positive and ER negative, and there are different types of mutations in ER positive versus ER negative cases. Usually it is benign, but sometimes you can see malignant transformation. And this malignant transformation can be both in luminal or myophysical component. Yeah, and I show you the next one. Over here, can you see this one? Because I didn't want you to go even further low, but there were multiple lobules over there, over there, over there. And then you can see that this looks like an interductal papilloma with central area of scarring, and you say that was might be disclosed interductal papilloma. But important thing is that you see these myophysical cells are so prominent over here. Yeah. So they are very prominent with luminal cells are compressed in that. And not only this, when you see this area, what is this? It can be easily missed. You might say this is a biopsy site, but no, this is actually this invasion. And you can see the mitotic activity in the background. And this patient developed metastasis. Yeah. So this was invasive component over here. So if you see, it is got malignant adenoma, if you see carcinoma arising with that, or if you have got both component malignant, then you can call it as mentioned. Yeah, and you can see some ducts over there, so which is basically shows you that this is a nipple. So first thing is circumscribed. Second thing is over here that there is a jigsaw puzzle pattern. Yeah, and they are surrounded by basement membrane like material all around it. And there is another area which is over here. I'll come to that, where you can see some lymphocytic infiltrate to it. Yeah, next one. Yeah. Now, not everything is adenoid cystic carcinoma in the breast. If you see this filiform pattern, where you see basement membrane like material. But there's another component over here. What would you call this? Is it also a syndrome here? Is this also syndrome, or what does it? It shows lymphocytic infiltrate. I'm giving you a clue over here. Exactly. Yeah. Background cells are positive too, but luminal cells are very strongly positive. This similarity between the two either. Yeah, CD117, as you can see over here, is positive in syndrome muscular, even positive in adenomyopathy. Yeah, so it cannot help you to differentiate the two. Yeah? And But obviously you have to be aware if you are doing the pathology that any skin lesion can come. Cells are basaloid and the pale larger cells, and there are specific genetic mutations in there. Okay, and as we discussed that you can have a hybrid tumor. Now this is an small diagnosis after discussing all that. Sorry? Okay, yeah, you're absolutely right. Now but glue that just having these sort of basement membrane like material, I find it difficult. No immuno has been in that. I mean, on the book, go over there, you might say that, oh, this immuno, that immuno. But if you're doing it practically, then you will find that this is very useful and very simple test. I mean, again, just wanted to show you the immuno. You know, CD117 positive in epithelial cells, CK7 again positive in the luminal cells, CK56. You can see it's not unique for it, like CK56 is there. I had two examples where it was negative. I'm not saying it's always positive, but I just brought this to bring the point that you don't rely on just immunohistochemistry over there. And this is the P63 which is showing my epithelial cells. But the important stain is because I have taken out this from the file and I had to resave it. Only day before yesterday, when I was in Karachi, I received this slide and just put it in there because I thought this is very important. So the block was in the hard drive, they had to bring it from other place and they did the immuno staining. And sorry, this is special staining, and you can see this membrane material PS positive and HN blue positive recently. And when you see these two peaks pattern, then you can say this is adenoid cystic carcinoma. So adenoid cystic carcinoma basically again is a biphasic tumor consisting of epithelial and myeloepithelial. Like this. So you have to be aware of all these different subtypes over there. And as I said, PS positive material as well as HN blue positive mucin, very important. So classic subtype, as you know, that this is the better prognosis contrast to the other two subtypes. Yeah. This stopped me to want to ask something because I'm just conscious about the time as well. The next. Okay, move to next here, right? Okay. Yeah, thank you, Madhavan. Okay, now what you can start putting up. What is your diagnosis? This is something we quite often come across, isn't it? That is it just a columnar cell change? Is it a flat epithelial? Yeah. So your vote can be counted, although I don't know how much you would vote counted here, but yes, at least in this one, you will be vote counted. Okay, one more person to go, but I can continue because time is short. Okay. So other is quite a good number, 80%, which is very good, but majority thought, you know, those are the things. So what is the thought about the other? Okay. Sorry? Epocrine change, okay. What else? I should have put in the differential diagnosis, that's a good clue. We'll discuss that in a minute. Anything else? Okay. Signature change, okay, what else? Just remember, because my memory is short, sometimes I take my phone out to make a call, and I forget to make a call, so I might call them. I'm used to that. What we did, but the receiver is on the other end. Then that is making it sort of. Yeah. Okay, we can come back to that also in a minute, okay? Next, case number 5 here. Just hold it over here. Next one. Just make it so. So don't be. Okay, next. Yeah, this. Yeah. Four more people quickly. Couple more. Okay, fine, yeah. In here, okay, 31% thought flag DCIS, 69% thought FEA, and okay, I can tell you that this was the flag DCIS, and I'm going in a sequence. You should look at it and secretion in the lumen, but there's a secretion. Yeah. So when you are thinking about making a diagnosis of flag atypia or flag DCIS, just think about it and look at the cytoplasm. You did mention somebody says apocrine thing, but apocrine simple ER, and it should be negative. Or if you've got androgen receptor, you can do androgen receptor to be positive. But once you develop your eye to identify apocrine, then you don't need to do those immunos, because then it will be waste of resources. Yeah. So, but over here, across to this, compare these two. Yeah, you might say this is more or less similar. One thing, if you can go back to the previous, in this middle one, let's go back to previous. Just one more, behind. Go, keep going, because I should have brought this slide over here. To be more dispersed and something here, and you may start seeing nuclear. Yeah? So this is the first thing you need to see the gene in contrast to the nuclei, but usually those are smaller SN9, like very small one. In athletic epithelial ATP, you may have become a bit larger, slightly larger compared to that. And in hormonal changes, you always see uniform. Look at all around. If everything looks the same nuclei, then it's hormonal change. If it is a focal area, then it's probably it's flat epithelial ATP. Go back to. So middle one was flat epithelial ATP, and in contrast to that, in the last one, you can see that the nuclei are high grade. In, as you can see, the top layering, multi-layering, and darker nuclei. You don't know whether I have got next slide. Yes. Yeah. Can you show one another? They go side by side with micropapillary flat. Between FPA and that. Sometimes just hyperplasia, nothing less like that columnar hyperplasia sometimes can look very, very bizarre. Look at the nuclei. In that nuclei will be longitude elongated, not rounded. When it becomes rounded, then in the department we have quite often this debate, but some of my colleagues bring there and say, no, it is FPA. Because they are sometimes disorganized too, and you start worrying about this. Yeah. So this is and you unnecessarily avoid the surgery in those cases. Tomorrow we'll be discussing what is the management proposed in the Europe. But what I'm saying that it is important to have a correct diagnosis. So patient, the clinician will be making the decision about the risk factors. This patient might have some other risk factors too, and might have end up having different type of treatment. It's very important to get the right diagnosis, whether this pregnancy is like thing, columnar cell gene, or flat PPR, or flat DCIS. I put this just very, I thought it's a very basic thing, but it's very important to have a clear concept to differentiate these simple and common things. I mean, I'm sure you see on a regular basis, and this question comes to you, and we may be discussing with your colleagues as well. So flat epithelial ATP is characterized by replacement of basically it is within the TDLUs. You can see that there are epidermal snouts like you see in columnar cell gene. One thing I forget to mention that if you want to differentiate from columnar cell chain, it is just a morphology because CK5/6 NDR is not going to help you. They both will be negative for CK5/6, they both will be positive for ER. So if you start doing those screening, then more columnar cell chain will come into your differential diagnosis of FEA. So this does not. Only thing helps is that these nuclei become round and uniform in appearance, and it is like a low grade DCIS. Whereas in flat DCIS, nuclei are high grade, with more much darker nuclei. Yeah? And sometimes if you start looking for it, and like often even in the core biopsy, I see somewhere there are some micropapillary structures there or there. Because this goes side by side. If you see the micropapillary DCIS, you quite often found some ducts where there are no micropapillary, and that fulfills the criteria for flat DCIS. So pure flat DCIS do exist, but what I'm saying is that you see in combination with micropapillary DCIS, and if you want to gauge your eyes to say what the flat DCIS is, look at those cases, and then you can develop the image. Okay. Case number 6. Okay, just hold on. Okay. You have opportunity over here. If you are ready, then you can go for yeah. You can start moving. Raise your hand in case if you have voted and yeah, please. But our receiver is on this end, so although I did try some of your voting back on the end of the room as well. 3 more people if they can. 2 more. Okay, at least the majority has got, we have got some ideas over here. Can we go next? Okay, so good number. You see that equal, basically, I would say people thought DCIS and other. So those, what was the other in the mind of the people who thought this other? Sorry? Collagenous process, okay. Anything else? Or was it just collagenous process? Would you call it B2? Just like I just, there are no cysts there. In that you see erythropoietic secretion, it's like a flat single layer. Yeah. And then again, depends upon what you're thinking, cystic hyperplasia or cystic hyperplasia. Then the both are there. So in that you see big cysts with secretion in there. But here, was there anything else besides collagenous process in that? You're right, there was a collagenous process in there, but there was something else as well. And that's what happened. One of my colleague thought this is a collagenous process. He reported it when I was reviewing for the MAT. I thought it's not right. It wasn't blank, but what you're trying to say it was round, regular, monotonous nuclei, and then we give little bit this type of cohesion. Yeah, and I have made it point, you know, that if you look at the previous slide, just go back to that. Just go back. Yeah, now most of this was like this lesion. I have, again, I can go on slide and show you the case. There was a big cluster over it. Most of this was like this. And people can easily, it's only this area where it shows this type of cells, which can easily be missed. So I have projected you to show you that, you know, look at carefully. If you just look at this one, you say this is collagenous process period, B2, that will show. But when you see this, then and what is the B score over here, by the way? B3. We'll come to that one. Okay. Next. Next. Yes, sir. Yeah, let's continue. Okay. Next. Next. Okay, start voting now. Very good. You know, people make their mind so quickly that one more person. Okay, great. Next. 100% voting over here. Other. So 58% thought DCIS. And I think remaining people thought this is the other. So what is the other diagnosis? Usman already has said it, but I don't want him to say that. What is the other diagnosis? Sorry? Sorry? Florid LCIS. Very good. What is florid LCIS?
They are because they are occupying the low hydrogen.
I'll come to that in a minute. Just remember if I forget. Okay. Next. Okay. I've just projected one field only. If you're ready, then we can go for polling. Okay, you can start polling now. These are everyday cases. You agree with me, yeah? It's not that I have taken out some difficult case. I just wanted to share with you that I have gone through from your stage 2. So I know that where we can have difficulties. I've learned those things over by making mistakes and by doing your experience. Now just wanted to share my experience before I did that. So yeah. Okay, we can go next one. So 65% thought other. So what do they thought other? Very good. Yeah. And this is a pleomorphic, and what B score will be? B5A, because that will be treated as like high grade BCIs. Yes? Anything? Okay, next. Case number 9. Okay. When you see this case, it's good that you people are participating very quickly. I hope that I will be able to finish all the cases in 9 minutes. Okay, next. Yeah. Okay, what is your diagnosis? You saw that you have an e-cadenial staining. Yeah. Raise your hand and make it good thing. So 14, 4 more. Great, one excellent. Let's start. Okay. So 72% thought this is a lobular cancerization. Yeah. And none of them thought this is something else. Okay, we'll come to that in a minute as well. So, I mean, this sort of things, obviously, if you are even wrong, it gives you some lesson over there. It's not something is lost. It is, it shows you that it can be beneficial. Okay, next. We can go to discussion. Yeah. Now, this one you all saw that, and we discussed that. Here you can see that this is e-cadenial staining, the cell in between that, they are basically negative for e-cadenial. So this is incytolobular neoplasia. Yeah, and then you can see collagen 4. These are old slides, sorry. So that's why this is bit paler and taking it from the digital. So they, not taking directly from the slide in the camera, because I prepared all my this talk when I was in Dubai, because I didn't get much time when I was in the department. So it was extremely hectic. So I was just doing it from the digital slide access I had remotely and capturing the images over there. But I'm glad. I was worried that it might become pixelated. At least it's showing me the image decent, not excellent as I would like to, but this is showing, and you can see collagen 4 staining over there. So see that there is a necrosis over here, and this is a calcification, and e-cadenial staining is negative, but at the periphery you should see myophyseal cell. Again, this is an old slide. I had another new slide which I put into the other presentation, but not in this one. I should, because they both treated at different time, but always look for the control at the periphery myophyseal cell. There will be positive and e-cadenial. It shouldn't be a false negative staining. Yeah? So, and then there is a central area of necrosis. So somebody said florid, but not they said pleomorphic. Why not pleomorphic? They treat it florid differently. We'll discuss this tomorrow. But why not? Even in my region, I remember that one case came from. Calcification does not tell you that this is pleomorphic. Nuclei should be pleomorphic to call it pleomorphic. Otherwise, this is florid and B4. Okay. So for that, you need to have a pleomorphism over there. Okay. Next one. And this one, obviously, you are absolutely right that this is also look very apoprytic. And don't miss out, or quite often, even classical ones sometimes can look apoprytic, because type B ones. There are two types of classic SCS, the type A, type B. Type B cells are a bit larger, more eosinophilic cytoplasm, yeah, and sometimes can look big. But here, what you are seeing, that prominent nuclei in many of these cells, and the cells, slightly variable in size and shape. So this is a negative for e-cadenial, and you can see this internal control over there at the periphery. This is a recent case, so staining is a bit more preserved. compared to the other. So that's what you look for, and exclude that there is no false negative spin. So yes, this was pleomorphic LCIS, and it should be regarded as P5A. See this one, beta catenin negative, E catenin positive, beta catenin negative. So those who thought this is a globular cancerization, do they want to change their diagnosis? Anybody? You know that LCIS is not always negative for E catenin. When you see the pattern, classical pattern of this on HNE, I wouldn't do normally immunostaining on this. I would say this is LCIS period. But some of my colleagues, they do it. And they came to me and said, oh, this is positive for E catenin. So I'm calling it, as you said, I'm calling it globular cancerization or what it is that. They do beta catenin on that. And if beta catenin is positive, I'll ask them to do delta catenin on that. Although that antibody we don't have, we have to send it over to another reference lab over there. And if it is negative, can you see this? So this classical CIS can be positive for E catenin. Yeah, and then do beta catenin. Beta catenin will be negative. If it is positive, then do delta catenin. That will show cytoplasmic staining instead of nuclear staining. So if you say lobular cancerization, it will be B score B5A, isn't it? And if it is LCIS classical, it is B3, totally different management. So why this is not a lobular cancerization? When you see lobular cancerization, this is always to see high grade DCIS. Low grade DCIS don't do. To think about it quite often, you are in rush to see this central necrosis and large ductal area and say, yeah, this is high grade DCIS, let it go B5A. But when you go around, and if you see any classic LCIS, be cautious, because sometimes you don't see, lack of cohesion that often, like in that case, in that particular area. So you look for background classic LCIS. If you see classic LCIS, always do equilibrium, even if you see those, high grade areas. Okay, so this is the message over here that always if go for HNE, that Professor Ali Hassan was teaching. So our head of department, Thomas Klaus, he was my teacher, and he was always saying to me that go for HNE. If anything comes different, then don't make the diagnosis on immunostaining. And same thing was saying for pressure too. So just if it is come, then do another or do further things and find out what the clue is. Yeah. Okay. So as we just saw that there are three subtypes: classic, florid, and pleomorphic. Classic you always see consists of either type A or type B cells, whereas florid LCIS there are two specific criteria. One is looks like basically DCIS without much intervening stroma. You see large ductile like structure and very clustered together. And second criteria is that within that when you say extension, how much? That for the diagnosis of LCIS, classic LCIS, what is the criteria? How would you differentiate between KLS and LCIS? What is the criteria, minimum criteria you should have between KLS and LCIS? 50% of? Yeah. So one of the lobule. If this is the only single lobule, if there are multiple lobules, then you don't need that. So 50%, what should be happening to at least 50% of the SNI? What should be happening? That's not enough definition. What should be happening to the 50% of SNI? I can give you one clue: proliferation of globular epithelial cells. What is other thing which is people forget? Not only proliferation of epithelial cells, but filling the entire lumen. Not only filling the entire lumen, causing distension of the SNI. If these features are missing, then it is even not ALS. If this fulfills all these three criteria, proliferation of epithelial cells, filling the entire lumen, causing the distension of SNI, and if it is only one nodule, it should be filling more than 50% to call it LCIS, and if it is that. And on the core biopsy, quite often it is difficult. And what do we say in those scenarios? What is the terminology we use? Inside lobular neoplasia. Yeah, I quite often use it, which is not from excisions. It is just confined to the core biopsy. Okay. Now, florid, I'll give you the example. Pleomorphic LCIS, there's a mark due to the pleomorphism. Yeah, looks like high-grade DCIS, but only clue is that the cells are lacking cohesion. You will see dispersed cell and look bit more plasma cycloid. Yeah, neuron look, any look, you can have it. Yeah, and if you look at the background, you will always find some classic LCIS going side by side. Yeah, and then it gives you clue and then do the immunostaining immediately. Okay, so cometonecrosis does not make it pleomorphic. Cometonecrosis, you can see both in florid and pleomorphic. Yeah, it is the nuclei which differentiate between florid and pleomorphic. Okay. Next. Next. Some necrotic areas. Not the carryover or anything. Next. Okay, can start voting. Is it, it's more, it is metaplastic squamous cell carcinoma or something else? Okay, we can continue. Next. Oh, 18, yeah, good, excellent. Okay, so those who think is something else. Squamous, okay, what else? Yeah, I should have put that into the definition. Which one, low grade immunity? Okay, do you see necrosis in the low grade immunity? Okay, can we go to the next slide? So that was the only differential other those, yeah, or any other differential you have in your mind? Okay, this question, you can look at it. Now, first of all, look at this. First of all, it shows papillary like section, very circumscribed at the periphery. Yeah, so this is something coming up over here. If you want, I can go. Can you see this very peripheral? Yes, there is a proliferation of ductal or ductular structure, but this is smooth muscle myosin, which shows that this is a papillary tumor, although extensively necrotic, but you can see that I can give some information to them. I'm giving you a saying, although in necrotic tissue I don't give diagnosis, but at least if retinosquamous is not in your differential diagnosis, then you can say it's benign. Okay, next one. But in retinosquamous, you don't see papillary structure. You know that is completely necrotic area I showed you. All this necrotic area has got myopapillary cell layer over there. Yeah, and this is the papillary architecture over there. Next. And again, P63 also identified that beside squamous epithelial cell in that. Okay, next. So, and yeah, so this is basically intraductal papilloma with infarction and squamous metaplasia. So squamous metaplasia can occur in wide variety of conditions in the breast. You know, breast we think is a granular, but you see squamous metaplasia and it can lead to so much misdiagnosis. That could have easily said that this is a carcinoma basically. But as you can see over here, that this is a well-known fact. And I have quoted you a paper. See how old paper is this? It's not for a long time. That that this is not very old, but still old. And they see that this is squamous metaplasia, chondrite metaplasia, bone colonial, because all these you can see in papilloma. So if you see heterologous elements, see, I've just shown you squamous metaplasia, but if you see heterologous elements and everything, before making a diagnosis of malignancy in prostate. Okay, next. And this is what small is. Small look very benign. Yeah. When I selected this slide where you can see a large duct over there. Can you see this line by columnar epithelium? And then you are seeing squamous metaplasia. Significance is that it is occurring at the pericellular region, just at the border. And you almost always found this history of smoking. Then they usually present with the chronic abscess. This is not even. Yeah, they are repeatedly doing it. And when they do the biopsy, sometimes this is superficial. You see only keratinized lining epithelium. And people say this is but there is a possibility because of the site and all that, this might be a small. Yeah, and if there is any history of smoking or not, the treatment is by surgical excision. Okay. Now, as I was saying that squamous metaplasia in wide variety of conditions, this was a phyllodes. Benign phyllodes tumor as well as in complex fibroadenomas. Next one. Metaplasia, and you see some, that's the silicon reaction to the silicon, but at the periphery, you can see squamous metaplasia. And don't start worrying about does this patient develop, because the breast implant patient, they develop malignancy, but usually anaplastic large cell lymphomas, basically, yeah. But here you see very blurred looking epithelium over there. Next one. Region or something, basically it was a squamous cell carcinoma, because squamous cell carcinoma usually they are very cystic, isn't it? And you are seeing cyst over here, and then part is lined by typical squamous epithelium, but this is not atypical in the sense of neoplastic. This is basically okay. Next. 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 Okay, voting starts now. So squamous metaplasia of rectifier. So 29% other. Any other? Microcystic adenoid carcinoma. Okay. What else? Anybody else? Okay, we'll come to that in a minute. Yeah. Shall we look at case 12? This leaf, and he had a similar definition diagnosis. We reached when we made the diagnosis of oxygen. Okay. Next. So what is your diagnosis? Carcinoma with osteoclast-like giant cells, carcinoma with tumor giant cells, ethnic cell carcinoma, pilomatrix carcinoma, or other. Good. The more people, if they want to commit. Okay, we can go to the next. Sure. Okay, so other. What is the other diagnosis? Squamous? Squamous cell carcinoma, very good. What else? Adenosquamous, okay. You mean polymetric carcinoma, okay. Okay, we'll come to that in a minute. Anything else anybody wants to say? Okay, go to the next slide, we'll do the discussion, yeah. Okay, so we'll go to the case 11. Okay. Here you can see that this tumor has shown again biphasic pattern. There are a lot of these have got cells which have got, you can see the outer myoepithelial cell layer is intact on P63 staining, but obviously they are staining those staining within sleeping areas as well. Yeah, and one important clue is in that. Okay, you can see tubular structures over there. Yeah, and these are negative for P63 staining. The P63, yeah. So they are luminal epithelial cells. This is again a biphasic tumor. Positive for SMM, yeah, myoepithelial cells and luminal cells are negative. So now the diagnosis is obvious. Squamous cell. And then which adenosquamous? Low grade one. Yeah, and the crew usually is on HNE. I don't know whether I photograph in there, but what I see, what I find, even 3 or 4 people I remember, I mean, we see only 2 to 3 cases a year. But when I see these sort of structures with desmoplastic stroma, I usually look for a cuticle, little keratin layer inside the tumor. If I see, then this gives me a big clue that this is a low-grade adenosquamous carcinoma. Yeah, and that's what it is basically. That is a uncommon variant of metaplastic breast carcinoma. You know that now we should put so many things into non-special types. But when they talk about metaplastic carcinoma, they put 4 or 5 different categories, and this is one of those low grades. It can transform into high grade as well, but usually this is a low grade one. You can see variable degree of squamous differentiation in the first slide you saw, and later slide I showed you the tubular structures lined by 2 cell layers. And human may contain amorphous acidic material keratin. This is what I usually look for, and this is what gives me the clue. Yeah, and this is one thing I always look for when I see even 2, 3, and remember that there's 1 case over 4, and I ask them to repeat the biopsy because I can't make diagnosis the test. And on the repeat biopsy, there was not 14 over there, and we used to, grade 3 to issue a report on that. If it is superficial, then this is the syndromatous adenoma of the nipple. Yeah, it depends upon the location. Morphology is the same, this not different. This number 12. Okay, now you are absolutely right that here you can see, I think this is a CK56 staining. These cells are very puzzling, isn't it? You can see one of my colleagues said this is a cynic cell carcinoma. Put all those in there. But and then some people said there are these tumor giant cells, so it's probably giant cell rich carcinoma. Yeah. So all these differential diagnoses were there. But no, I said that there are squamous epithelial cells, and in some area I showed them the keratinization there. So yes, it is a metaplastic carcinoma. But my problem was that I never seen one which is a solid. I always see a cystic area in the center, which is metaplastic squamous cell carcinoma. And this is the first time. So I said this may be metastasis from elsewhere, or this may be metaplastic carcinoma, even pyometrics. But only problem is that pyometric carcinoma was that there were no ghost cells there. Say that coincident DCIS in the background. They are the same cells over there. Yeah. So there is in situ tumor which gives you a diagnosis clue. Yeah. It went to one of my colleagues and he was about to go and leave and he said, so you can take it over because I'm going away and it's a difficult one. I took it and it knew take a long time. I started looking because whenever you have differential diagnosis, primary versus metastatic, okay. I'm sure. Do you need me to? I'm sure these are all things written in all the books, so I will go to the case in the course. Yeah. Okay. Can you go next? There is no voting over here. I'll just put this to differentiation. So squamous differentiation you can have in both benign and malignant. Here, clear cutting is that you can see mucus secreting cells in that. Yeah. So you can see intermediate cells, you can see squamous differentiation, and if you do the staining for mucin, this will be positive. Yeah? That comes from mucoepidermoid carcinoma. Now, according to the book, if you do, how would you do the grading? You can do grading both ways. You can do by cellular grade, or you can do by nutrient breast, and it comes to the same grade. Yeah, I haven't tried myself doing because there are not that many cases anyway. Yeah, usually they are intermediate grade anyway. Okay, so again, I don't need to go into the mucoepidermoid. I'm sure all of you know what mucoepidermoid carcinomas are. But this pH staining quite often helps you if the next slide. One feature, just remember this thing, which I'm not sure written in any book, but so far in my experience, that is very helpful for me. Okay, next one. You can start voting now. Okay, anybody else want to vote or? Okay, we can go to next. Okay. The majority thought this is option E, low grade fibromatosis like carcinoma. And second largest was nodular fasciitis. So it's basically benign versus malignant, isn't it? And some people did thought fibromatosis and myofibroblastoma as well. Okay. Okay, next slide, please. Next. Please 14. Sorry, this is a bit lighter. But a little bit brighter. Okay, next one. One more. I think here you can see the cells properly and all the features you need to make the diagnosis. Okay, go from the next one. This is where you can start voting. Okay, next one. So myofibroblastoma, yes, majority is right, because you saw that roping collagen impact, yeah, that's very good. And you saw something that fat there, so you were right that you didn't thought it is in the fat. Okay, and this is a same thing as the conventional lipoma, quite common records. Okay, next one. Next one. Next one. Next one. Next one. Next one. Stop me if I'm rushing it too fast. Yeah. If you want to see a bit longer, just tell me. Okay. You see, this was a spot diagnosis. That's what people have done. 14 people have already done that. Anybody else wanted to? Okay. 15 so far. Let's go next. Nodular fasciitis. Yes, it should be right. Yeah. Because you see this myxoid sarcoma or mucoid sarcoma, you can see that you can see it will be large, you see some lymphocytes there. And one other thing which I find very useful, you see this eosinophilic material, which is probably fascia. And quite often in the periphery, I do see fascia there as well, which helps in the differential in making a diagnosis. Okay, now fibromatosis, first one was that, because what I was saying to you is that, obviously you can't make a diagnosis of HIE. Yeah, you can suspect it. When that was the purpose. I mean, if you got this wrong, don't worry about it. You never make the diagnosis independently on HIE. You can cross to other disabilities. No, this is a change. Next one. You can see beta catenin, this is the clue. Yeah, so beta catenin staining, it should be nuclear, not cytoplasmic. If it is nuclear staining, it will give you the diagnosis. And then obviously you consent for cytogenetic. I don't know how often you do it. Immunostaining which can help people to differentiate different types of spindle cell lesion, which you can find in a book. Yeah. So this fibroblastima we have already discussed that it was and was most of you were right that they were ropicology in their spindle cell in the form of short fascicles and all that. Yeah. Okay. And in the past it should be said that mostly male, but male and female both, you can see that. Important thing is that it will be positive for both CD34 desmin ER and PR. Yeah. All combinations. Okay. And nodular fasciitis again we have discussed, which is a sometimes very rare, but one thing is superficial. Yeah. And it depends upon what stage you are seeing. If early stages you are seeing it, you can see mitotic activity and everything. Usually it's long and well demarcated from the surrounding tissue. And at the point, as I said, you can see a little facial here as well. And secondly, you see extravasate RBC, myxoidelia, some lymphocytic infiltrate. Okay. Then, I mean, beta catenin will be important things that you do. Beta catenin should be negative. SMA or less than can be positive in many microplastic freedom. Okay. Okay, last two here. Okay, next one. Next one. Next one. This is cytochrome 19. I know it's difficult, so just an idea what you thought. Where will you? Okay, so 50% thought phyloid is tumor. Very good. May I know why you thought phyloid is tumor in this one? Sorry? Sorry, tell me. What was the heterologous element in it? Okay. Most of that was sarcoma, it was second that I thought. You may be right for the wrong reason, but I thought that was the interest fact. And it is very important, you know, that last time when I came, I showed you that differential diagnosis, that pitfalls, how often you can make a diagnosis. Now, since you have raised this point, liposarcoma, if you see liposarcoma, what will be your diagnosis of that is benign, borderline, or malignant? Liposarcoma does not make it malignant. Yeah, just keep remembering that. When you see this liposarcoma, which is a basically locally aggressive tumor, not malignant. Yeah. Okay. Any other differential? Any other thought? You people also thought phyloid, yeah? On the same ground? Okay, no problem. We'll come to that. Is 17? Keep in this mind, although I didn't put a notice on the biopsy to start with, but okay, next. Next. This is positive for SMA. Yeah, some of the cells, not all the cells, some cells are negative too. Okay, next. What is this? This is high power magnification of SMA. Beside, within the wall of the vessel, this is plastic cells are. Okay. So what is your diagnosis? Start moving. Okay, so we can go next. Using wide variety of diagnosis over here. Yeah. Metaplastic carcinoma, sarcoma, and vasculitis, tumor, other. So what is the other? Is there anything else other people thought? Well, why is it thought? Hmm? Right? Very good. Okay, come to the excision of the case number 16, the one before that, yeah? And this is an excision area, yeah? Looks similar cell, yeah? Because I don't know how many, more than 50 blocks of this for excision. And this is one of the area, one of the block. Can you go further? CD34 negative, you know, then like some people said fluorides over there, and fluorides usually are positive for CD34, but only as they become malignant, they are less and less positive. About 60% of malignant are positive for CD34. That's why I'm doing constantly CD34 over there. Okay, next. 10.5.2. Now it's obvious, not hidden over here. 10.5.2 positive. Next. MNF116 positive, at least focally. Next. And this was the only area positive of the whole tumor. You know how many, maybe the one which I did the understanding, not every block I did it, but SMA, this is also positive here. Next. So now what is your diagnosis? Does this make you think differently? Okay, you can start voting now. Okay, next. So metaplastic carcinoma. We'll come to that. Sure, let's go next one. Now, in one of the blocks, I think on the third for the block section, I found this area. Now, what is your diagnosis? Fluoride. So you can see that, you can go next. And this heterologous element as well. Yeah, this is proof, obviously, osteoid differentiation because neoplastic cells are directly and they are malignant. Yeah. Okay. So, well, just continue now because we have already given a diagnosis. Yeah. Okay, next one. So there can be anomalous expression of cytokeratin and P63 malignant fluorescent tumor. You have to be very careful about this. Yeah, just by seeing cytokeratin positivity, don't make the diagnosis of fluorescent tumor, and cytokeratin negativity don't make the diagnosis, don't exclude the diagnosis of metaplastic carcinoma. Okay, next. Yes, sir. And this is the cytokeratin staining. over here. Next, within that, remember that where it was SMA positive, yeah. And what we said that this is the hidden side imperative. So yes, this is now obvious. Okay, next. And this is on the excision. Remember that I was saying the clue, a small rounded structure, which was obviously couldn't make anything over there. But when you start looking at it, this is squamous type DCIS. Yeah, and this was also, so you could easily now make a diagnosis as a primary tumor. And it is a very blunt looking, it's fibromatosis like carcinoma, basically metaplastic subtype. Yeah. Okay, next. So again, you have to be very careful that sarcopenia can be obviously in biopsy. You can't make a diagnosis as truly sarcopenia negative and I need to see some cell. Although one or two cases which I sent to another colleague in Leeds, and we come to a consensus that is a metaplastic carcinoma cannot be anything else. But I usually make sure that you see some type of in somewhere. But P63 I found very useful. I always, whenever metaplastic carcinoma is in my distribution metaplastic carcinoma, we always do P63. And it's quite high number of those cases are P63 positive. So in this paper, they have said P63, SMA, and CD10, at least two of the markers are positive. Yeah. So we do as a part, don't do CD10, but P63, SMA as a part of spindle cell protocol, we do all those. And often they are positive of P63 and negative for all the markers. And that is in fact for me sufficient to make a diagnosis of a metaplastic carcinoma. I think this was the last slide. Can you look at it? Yeah, I mean, I've got. I think next speaker is coming, but I've got two more cases, but I think I should stop over here. So first of all, I want to say thank you to Mariam to start with inviting me over here, and also great big thanks to Suhail and the whole IT team to make it working, because I was a bit nervous when I came over here, but they sorted out and it worked very well. Thank you very much for doing that. And thank you to the participants who made this interactive and gave me the opportunity to deliver the message of what I wanted to give you. I hope you have enjoyed it. So we have got 28, so one more, yeah. 21. Thank you very much once again. Thank you. That was sorted out. Mariam, thank you for your patience. This makes the difference because people have communicated, participate that information.
Microscopes and all, yeah, that's very.
जगह प्रॉब्लम होती थी व्हाट इज दिस इवन यहाँ पर पीसी में हम अंदर जाते हुए मुझे लगे कि व्हाट इज दिस मतलब वो ज्यादा नहीं लेकिन यहाँ पे एयरपोर्ट की जब कराची एयरपोर्ट पे जाना इसने कहा आई वांट टू सी दिस व्हाट है मैंने कहा ये अगर करोड़पति होगा कौन बनेगा करोड़पति उसमें जो वोटिंग करते हैं वो चीज
ये डॉक्टर अली की आपको सेक्शन अपलोड करके रखूं, इनकी डॉक्टर सेलेक्ट करने के बाद
हाँ, जल्दी प्रेजेंटेशन के बाद नहीं, 2 बजे।
एक दफा चेक
आपके पास है उसमें बना हुआ पावर इसमें करने शेड्यूल में मैंने जो है ना पोस्टमार्टम के लिए 2 हफ्ते हमारे डायबिटीज और वो है मतलब से 2 हफ्ते एक दिन उसका जनरल आसिफ दवा उसकी पोस्टमार्टम की जाएगा इसके बाद जो पोस्टमार्टम जमाने कम हो गया जमाने फोटो कौन काटेगा ना आ जाए मैं उसको कहता हूँ फिर उस जमाने में 4-5 सब एक्सपर्ट थे अपने फील्ड से तो हम हमारे स्कूल भी बड़ा सा जा रहा हूँ एक्सपेंशन करते रहते हैं तो वो भी इसी करके ना तो सीनियर लोग उधर ही ये सब मुझे कितने साल हो गए 7 से पीपीडी फेस्टिवल भी था लेकिन हमको साथ फेस्टिवल कोर्स में शुरू किया था इसको सिलेक्ट करो मैंने कॉलेज की मॉडल लाइन को भी सबके सब फिर उसके बाद साइकोलॉजी सर्वाइकल साइकोलॉजी कोई वो नहीं हालांकि मेरे पास फंडिंग है आई कुड असाइन माय सम बिकॉज़ मेरी स्कूल है तो जो ऐसी कोई बजट आती है उसको कोई अपने नाम में कभी छोड़ के जब मैं ये सारा भी एक्स्ट्रा बर्डन देता हूँ मैं आई डोंट वांट समबडी टू प्ले फिंगर एंड से दैट यू विल टारगेट गवर्नमेंट नहीं है या नो फील I said, I was next. But it's difficult to recover. That's the मुझे तो चीजें कई बार बस टाइम नहीं था
अच्छा इन दोनों को
आखिरी स्लाइड जो मुझे
साइज से क्या
Thank you very much for the organizing committee.
Our next speaker is Professor Dilip. He's a professor in Institute of Pathology, and he's Associate Dean of International Affairs, Faculty of Dentistry, University of Malaysia. He was past president of International Association of Pathologists and this talk is again a recorded talk.
Good morning, everyone. Thank you very much for the organizing committee for inviting me to share our views on salivary gland tumors. I'm sorry that I was planning to participate physically, but due to various circumstances, I'm not in a position to come. Hence, I'm sending this lecture online. Let me share my screen first. Right. So what I'm going to talk to you today was on salivary gland tumors. We know when it comes to head and neck region, these are the that we are getting biopsies from as head and neck pathologists, salivary gland, and in addition to thyroid, of course. I hope you can see the screen well now. Now, what is the diagnostic approach for salivary gland tumors? It's not different from main other organs in the human body. So, of course, we need clinical data in some cases. It's very important, but not all cases we need clinical data to come to the definitive diagnosis. But some of them, some entities, clinical details are going to be very, very important, especially if you are dealing with the CXPA, the duration is very important. If you are dealing with polymorphous carcinoma, the site, whether it is from the minor glands or major glands, is important. So likewise, clinical details are important because some tumors we know occurs more frequently in younger people. Again, similar to many other tumors in the human body, the pattern of cell arrangement, cellular arrangement is exceptionally important in salivary gland tumors. We know many different patterns of cellular arrangement, with prominent duct differentiation, with cribriform arrangement, with fascicular, etc. So many different patterns of tumors. So there are different groups of tumors which belong to different patterns. So that's helpful. And the nuclear cellular details, of course, is exceptionally important in order to diagnose some salivary tumors. For example, if you see a salivary tumor with angular nuclei, so with basaloid appearance, that's more towards adenocystic carcinoma. And another thing that we cannot neglect is special stains. I think the younger generation of pathologists mostly they forget about the value of special stains. It is important in some instances in salivary gland tumors to come to the definitive diagnosis. And especially if you are working in a resource-poor setting, special stains can be very helpful. When we were young pathologists, that is how we diagnose. We did not have immunohistochemistry or molecular facilities. Now, of course, immunohistochemistry is part and parcel of our diagnostic services. Yes, it is very helpful. But again, when immunohistochemistry came into picture, not many people use immunohistochemistry and not many people believe that immunohistochemistry has a role to play. But now we know it has a big role to play in salivary diagnostics. What about molecular? Yes, especially the last edition, the 5th edition of WHO Blue Book on head and neck tumors, you can see we have described many molecular markers for most of the salivary tumors. Now, these are the latest WHO classification that we did a couple of years ago. Unlike the previous 4 volumes, it has the previous 4 editions rather. This has 2 volumes. We try to include more details on some of the areas. Now, altogether, we have 15 benign tumors and 21 malignant tumors, totaling 36 salivary tumors coming. Now, this first case is a 87-year-old male presenting with a lump at the back of the mouth close to left tonsil. Now, this is a low power view. All what you can see when you see the low power view, you can see the surface epithelium, intact surface epithelium. The surface is not ulcerated. And then you have very solid area of the tumor and also the thin strands of tumor with this low power streaming in the peripheral parts of the tumor mostly. But the most characteristic feature that we see here is the presence of clear cells. And very well. Clear not very much much of cellular atypia. But again, you can see bands of collagen fibers going in between tumor cells and bit of hyalinized areas. And here it is more clear. What you can see here is very myxoid stroma with the spindle cell, the collagen fiber bundle going in between tumor cells. So again, the tumor cells are mostly clear cells. And here it is even more clearer. A lot of bands of very hyalinized collagen and myxoid stroma. The tumor cells are sparse in this particular area. Now again, more of the same thing as I said earlier, a lot of myxoid stroma with collagen and very marked hyalinization, right? Within the hyalinized background, you can see thin strands of tumor. This is characteristic for this particular tumor. And the high power of the same thing, again, you can see a little bit of myxoid areas and hyalinized areas and clear cells. And here what you can see is some ductal structures, right? Some ductal differentiation. When, as I said at the beginning, ductal differentiation is not an uncommon feature in a majority of salivary tumors. So here also you can see some ductal structures, and the mucinous stuff is noted inside the lumina or ductal structures. So if you want to make sure that what you are looking at is definitely mucin, you can do mucin stents. You can see these luminal spaces as well as some cells are positive for mucin. And what about immunohistochemistry? Now, when it comes to immunohistochemistry, as I alluded to you at the beginning, it plays a major role in salivary tumors now. Now, if you want to make sure that you are looking at a salivary tumor, CK7 is going to be very important and very helpful. But we know CK7 is positive in thyroid and lung, etc. But CK7 is very helpful in the context. Remember, in the context, if CK7 is positive, we know we are most probably looking at a salivary tumor. And P63, we know P63 is a basal keratinocyte marker as well as a myoepithelial marker. So you can see the very strong nuclear positivity of P63 in this. Right? This tumor also positive for P63 and negative for S100. Is it a mucoepidermoid? Now, CK19, very focal positivity of CK19. We know CK19 is a marker that we use to decide whether they are odontogenic tumors in our context. But sometimes this particular tumor also can have focal positivity for CK19. But if it is of odontogenic origin, you will usually see more diffuse positivity. So what is the diagnosis? Is it a mucoepidermoid carcinoma? The sclerosing, now we have a sclerosing subtype, clear cell subtype. Perhaps not. I showed you it's a tumor with a lot of hyalinized areas with collagen fiber bundles separating the tumor islands and a lot of myxoid areas. So when you have any clear cell tumor, something that we would like to do is EWSR1 rearrangement. So that was done for this tumor and it was positive, and this is a case of hyalinizing clear cell carcinoma. Yeah, but some areas can look like mucoepidermoid in this, but if you do EWSR1, it is the rearrangement is positive in this. Now, if you have a doubt whether it is mucoepidermoid, so you can do ML2. Now, immunohistochemistry, it's positive for a lot of markers, but most of these markers are not very helpful to say if it is definitely clear hyalinizing clear cell carcinoma, because these are positive in some other salivary tumors, including mucoepidermoid carcinoma. But as I told you earlier, S100 negativity and P63 positivity is a feature of this tumor as well as mucoepidermoid carcinoma. But this is mostly negative for myoepithelial markers. So the definite diagnosis for this is hyalinizing clear cell carcinoma. Differential diagnosis, as I said earlier, mucoepidermoid carcinoma, and also epithelial myoepithelial carcinoma in some areas of this tumor. And of course, clear cell microcystic adenocarcinoma, that is a new tumor which was diagnosed or described in the new classification. I forgot to tell you something. In the new classification, out of 36 tumors, 4 tumors in the benign category are new, and the 2 tumors, microsecretory carcinoma and sclerosing microcystic adenocarcinoma, are the 2 benign malignant new entities in the new classification. And also clear cell odontogenic carcinoma in the context we need to consider. So highlighting clear cell carcinoma, these are the WHO criteria that we have put forward in the latest classification. Essential, all the tumors have essential and desirable criteria in the latest edition. Next, cords and trabeculae of clear and eosinophilic cells in a hyalinized, more preferably myxoid stroma is present in almost all tumors, and desirable provided you have the facilities. I know countries like Pakistan and other South Asian countries, Bangladesh, Sri Lanka, we do not and the tumor is from the parotid tail. Right, now this whole mount section, so you can see it's very cystic. So you can see the material inside in the cystic spaces, and you can see some cellular elements around these large cystic areas. Now, when you go to little high power, you can see these cystic areas I showed you in the previous slide, and a lot of eosinophilic looking secretions inside, and you can vaguely identify with this view. You have a epithelium covering these cystic spaces, and significant features. Some areas you see the papillary configuration as well, and you see massive lymphoid stroma, even with germinal center formation. You can see germinal center formation and a lymphoid stroma. So we know when we have lymphoid stroma, papillary configurations, and mostly bilayered ductal structure, diagnosis is difficult. We diagnose it as a Warthin's tumor or papillary cyst adenoma lymphomatosum. Is this a Warthin's tumor or papillary cyst adenoma lymphomatosum? Now, usually in Warthin tumor, you have a bilayered, as I said earlier, bilayered eosinophilic cellular layer on the surface. But here it is proliferating. It is multi-layered epithelium, right? So it's slightly looking like slight more towards squamous differentiation, slight. But here, when you look at the high power, you can see very clearly the papillary configurations, and they are not just bilayered, they are multi-layer epithelium, right? So with eosinophilic cytoplasm in it. And here it is very nondescript, the very flat epithelium, not like what we see in Warthin's tumor, nice bilayered epithelium with a lot of cytoplasm, but we don't see that here. And elsewhere in the tumor, you have this kind of cellular population. You see they are, the cells shows definite degree of cellular atypia, nuclear and cellular pleomorphism, and you can see some cells with bubbly cytoplasm probably containing mucin, and occasional mitosis are present, and some cells show vague epidermoidosquamous differentiation. Here it is more clearer, and some cells have very granular or bubbly cytoplasm suggestive of presence of mucin, and some nuclei are pleomorphic, the large nuclei, smaller ones, etc., with prominent nucleoli. And here it is even better, despite the fact that we saw definite Warthin-like areas. Now here it is different, right? Here you have differentiation. And the lymphoid stroma, in between the lymphoid stroma, again, you have more epidermoid looking the islands. with even the surface epithelium, within the even the thin areas, you can appreciate the presence of mucus secreting cells. Again, one of the clues to differentiate it from both ends. Now you see multi-layered. Now if it is both ends, there's usually bilayered nice eosinophilic cells with nice eosinophilic cytoplasm. Some areas can have ciliated appearance. Now you can see cilia in some of these cells. Again, multi-layered epithelium with underlying lymphoid stroma. And can anybody guess what this molecular test is? Yes, this is break apart fish for mammal 2. So you can see it is nicely showing the rearrangement, and this is mammal 2 positive. And despite the fact that you have Warthin-like features, now this is not a Warthin tumor or papillary cyst adenoma lymphomatosum or lymphomatosum, as we previously said, but this is a case of mucoepidermoid carcinoma. This is the new variant that has been described in recent years, the Warthin-like mucoepidermoid carcinoma. Now, please remember the fact that mucoepidermoid carcinoma, we know by far the commonest salivary gland malignancy, especially in children. This is the commonest malignancy in salivary glands, but it is not easy to diagnose. More often than not, you can go wrong when you are hit with a variant, rare variant of mucoepidermoid carcinoma. Here you can see so many, more than 10 different types of mucoepidermoid carcinomas. Classical, that is what we know. We divide that into the high grade, intermediate grade, and low grade, depending on the cellular component and various other features like presence of mitosis, anaplasia, and vascular invasion, perineural invasion, etc. But they are the classical ones, intermediate, sorry, high grade, intermediate, and low. Then you have clear cell variant. Sometimes mucoepidermoid carcinoma can be completely clear cells. Now you need to remember the fact that there are a lot of salivary tumors, other salivary tumors which can have clear cells, as we just discussed, the hyalinizing clear cell carcinoma, actinic cell carcinoma, epithelial myoepithelial carcinoma, to make it even more difficult. A lot of benign salivary tumors, including even common pleomorphic adenoma, oncocytoma, myoepithelioma, they can have clear cells, right? So clear cell mucoepidermoid carcinoma variant, that is something you need to remember, because when you have a clear cell malignancy in the hedonic region, we know it could be either salivary or odontogenic in origin. In addition to that, one need to consider the metastatic the carcinomas like renal cell carcinomas. We have seen a significant number of renal cell carcinomas that, with clear cells presenting in the hedonic region. Then we have the oncocytic variant, and the combined variants are always possible, clear cell and oncocytic. You can get clear cell and sclerosing. You have the Warthin-like, you have spindle cell. It will be a challenge when you have that completely in a small biopsy. And the mucinous, the ciliated, mucoacina, and sometimes you get very high-grade transformation. Very difficult to say whether it is a poorly differentiated squamous cell carcinoma or mucoepidermoid carcinoma. And rarely, remember, rarely we can get central mucoepidermoid carcinomas inside the mandible or maxilla. So that can be challenging because there is another odontogenic cyst called glandular odontogenic cyst, or in the past we called odontogenic cyst. So that is very difficult to differentiate from low-grade central mucoepidermoid carcinoma. This is a challenging case that we published some time back. Pigmented and spindle cell mucoepidermoid carcinoma. You need to remember sometimes you get melanin pigmentation in mucoepidermoid carcinomas and spindle cells. Of course, other areas you might, if you're lucky, you will see that the proper mucoepidermoid carcinoma-like areas. Right, we'll move to third case. This is a female of 64 years, and this time it's a submandibular mass. Here you can see the normal submandibular salivary gland here, and you have a fairly circumscribed tumor on one edge of the salivary gland. Here, when you look at this, all what you realize is it is very eosinophilic. In pathology, we refer to that as oncocytic. Why we get oncocytic changes, oncocytic appearance, mostly due to increased number of mitochondria. Encapsulation of the tumor. Now you need to remember some salivary tumors are nicely encapsulated, even the malignant ones like actinic cell carcinoma or epithelial myopathial carcinoma. For that matter, they are very circumscribed. Here we can see this tumor, the main tumor, and it's breaking away small islands toward the periphery, right? The same here. So that tells us this perhaps be not benign, it's a malignant tumor. And here we see the similar features, but a little bit of cytoplasmic clearing in these areas and bit of ductal differentiation also there. Is something like actinic cell carcinoma. When you look at the nuclear morphology, they are again very round cells, uniform nuclei, little similar to actinic cell carcinoma. Here, but when you look at here, you can see in addition to this granular-looking cytoplasm, you have mucin, definite mucin in some of these cells. Yes, you can demonstrate the presence of mucin by doing mucin stains. You have to bear with me my throat because I'm just recovering from a sore throat. I don't know how far I can go on. So yes, as I told you, you have some clearing, cytoplasmic clearing, and very granular looking cytoplasm and tightly packed cells. And again here, the tumor islands arranged into small size tumor, the lobules, and some ductal looking cells there. And again, very marked eosinophilic cytoplasm looking like very oncocytic. This is P63. P63 is positive in significant number of cells. And S100, negative. You have a nice internal control. They are the nerves, but the tumor is negative. SOX10, again negative. And I told you, when you have a tumor which is S100 negative and P63 positive, in the context, if you are thinking of mucoepidermoid carcinoma, so that is the right context. Now, mammel 2 was done and it was positive, rearrangement. And this is again another mucoepidermoid carcinoma, but this time it is an oncocytic variant out of the many types that I showed you. This is a mucoepidermoid carcinoma with oncocytic variant, probably of intermediate grade. Mucoepidermoid carcinoma, I told you earlier also, P63 or P40 expression in the absence of S100 protein or SOX10, which is the case in this one, may help to differentiate mucoepidermoid carcinoma from other salivary tumor. That is what we said in the WHO classification. So the essential features for conventional mucoepidermoid carcinoma diagnosis, there should be mucous cells, intermediate cells, and squamous cells. Now the proportion of these cells can vary depending on what type of grade that we are talking about. If it is a low-grade tumor, it's more high-grade tumor. Low-grade tumor, it's more mucous cells. If it's a high-grade tumor, it's more squamoid cells. And it is desirable if you have facilities to do mammel-2 in a difficult case like this. Case number 4, elderly female, 82 years of old, and a parotid mass. And FNAC was done. It was reported as both in tumor. Now, when you look at this, it doesn't look like voting, is it? Right? So we have the normal salivary, right? Normal salivary gland, parotid gland here, and this is the tumor. Now you see the tumor with prominent ductal differentiation and some the papillary configuration, and significant lymphoid stroma is also there, and there is the secretions inside the lumina of these ducts. Now here again we can see the similar features to what we saw earlier. Slight cribriform look in some areas, but here more cystic areas with papillary configurations within. Here again the same thing. We will go to a high power to see more nuclear. Now you see, it's difficult in some tumors to decide whether it is malignant or benign just by looking at the border. This is very circumscribed. But when you look at the cellular features, they are not very benign. There is some degree of the ATPI is there. Now here, what do we see? The very prominent papillary configurations and the nuclear morphology. When you look at, you can see very bland looking, almost ground glass looking nuclei. Now, as most of you are histopathologists, I believe, so you can see there's a little hint of thyroid, papillary thyroid looking appearance. Now that is usually the case in this particular tumor. You see, even if you want, you can see, you might see even nuclear overlapping in some areas and the fibrovascular course. Here it is very clear, very clear looking nuclei. This tumor, in most instances, when you stain this, you feel like it is slide is faded, but the slide is not faded. Actually, that is genuine appearance of this tumor. So a lot of overlapping of nuclei, and that is a very, very characteristic feature of most of these tumors in this entity. Here again, it's similar. I would agree, the almost ground glass looking nuclei, overlapping nuclei, so mild degree of cellular ATPI is also there. So you can see secretions in between, inside these luminal spaces. Again, here, very characteristic feature of this slightly looking like glomerular appearance, right? So it's another presentation of this tumor. Small islands. And sometimes you can have a lot of myxoid areas in tumor with different presentations of these cells, different arrangement, a lot of papillary configurations. And you can see this tumor, although it was in the parotid gland, now it is coming close to the tonsils, right? So the deep lobe parotid tumors can appear in the pharynx, and it's not very highly positive. It's probably less than 10%. But this is a case of polymorphous adenocarcinoma. Now, this I showed you some areas looking like cribriform. So this is a cribriform subtype of polymorphous adenocarcinoma. The seen a case like that some years ago. And polymorphous adenocarcinoma, immunohistochemistry can be very helpful in some cases. Now remember, immunohistochemistry, when you do, there is a very unusual combination. That combination is P63 positive, and the similar family of P40 is negative. That combination, S100 positivity and P63 positivity, but negative P40 in the correct context is very diagnostic of polymorphous adenocarcinoma. Of course, the essential features should be cytological uniformity, architectural diversity, that is why we call it polymorphous, and infiltrative board, at least in some areas. Especially in the periphery of this polymorphous adenocarcinoma, we call Indian piling appearance. You can see the single cell line streaming in between the connective tissues. So that is very characteristic of polymorphous adenocarcinoma, not in all cases. In some cases, if you see that feature, you can make your mind in a difficult salivary gland tumor. And if you have molecular facilities, of course, this is positive for PRKD family. They are either hotspot mutations or translocations. PRKD 1, 2, and 3, all they can be positive depending on the type, especially cribriform type. It is a very important diagnostic marker. But in the past, you may remember in the previous classifications, we called polymorphous low-grade adenocarcinoma because we thought all polymorphous adenocarcinomas are low-grade. But now we know there's a spectrum. There's some tumors are of the high grade of the spectrum. Okay, we'll move to case 5. This is another parotid tumor, the female, 78 years old, and FNSC diagnosis suspicious of malignancy. And here you can see, again, surrounding parotid tissue and a circumscribed salivary gland tumor. Here, again, ductal structures. Now you can see very characteristic. bilayered ductal structures. When you see bilayered ductal structures, as a pathologist, you have a differential diagnosis. Not all salivary gland tumors have bilayered structures. Bilayered structures are usually there, that the inner epithelial and the outer myoepithelial cell layer. It's common in pleomorphic adenoma and also the basal cell neoplasms like basal cell adenoma, basal cell adenocarcinoma, and adenocystic carcinoma, and epithelial myoepithelial carcinoma. Those are the main tumors where you have bilayered ducts. So you don't need to think much about others. Polymorphous adenocarcinoma sometimes can have bilayered, it's most monolayered, but you can have bilayered structures. Now in this tumor, obviously we have bilayered ducts. I will show you in the high power. And fairly circumscribed. You see the adjacent parotid tissue. Here, the very marked cells with bilayered appearance and arranged into very prominent papillary structures. And here again, it's very clear. Now the outer cells are more clear. Looking, they are the myoepithelial cells. Then the inner cells are the epithelial or luminal cells, the epithelial cells. And you have slight hyalinization, not slight hyalinization, hyalinized areas, and also the luminal secretions. Here it is very clear here, the bilayering of the tumor. The outer cells are more clear looking. Right? So you can see the apocrine changes in some of these bilayered ductal structures. That's again a characteristic feature in a subgroup of this type of tumors. Again, the same with early apocrine changes. You can see some columnar, the cells, and minimal degree of cellular atypia, very occasional mitosis. Again, the apocrine secretions, they're very characteristic in this particular tumor, this subtype. Some degree of nuclear atypia is seen, and some cells looking like very granular, right? The cytoplasm is very granular, and some oncocytic appearance. There are definitely some oncocytic changes are there. Here it is very clear, a lot of oncocytic changes in this part of the tumor. So cytokeratin, the 7, yeah, it is strongly positive. And you can see it's strongly positive, especially in the luminal cells. And P63 is positive. Again, you can see it is characteristically positive here in myoepithelial cells here in this area. Now, this is a case of epithelial myoepithelial carcinoma. This I showed you, it had oncocytic areas, very prominent, and also apocrine area. So this is, again, epithelial myoepithelial carcinoma can have different types. Now, this is oncocytic stroke apocrine type. In addition to apocrine, the oncocytic type, you can have tripliform type, you can have basaloid type, you can have sebaceous differentiation. Remember, we have sebaceous adenocarcinomas in salivary glands, but sometimes you can get sebaceous differentiation in epithelial myoepithelial also. In a small biopsy, you might struggle to decide whether it's a sebaceous carcinoma or epithelial myoepithelial carcinoma. That difference is important. Sebaceous carcinoma in salivary gland is not a low grade or intermediate grade, it's a high grade tumor, but epithelial myoepithelial is mostly intermediate grade malignancy. And sometimes you get marked squamous differentiation in epithelial myoepithelial carcinoma. So as I told you, the differential diagnosis of epithelial myoepithelial carcinoma, you've got to consider other salivary tumors with bilayered ductal structures like adenocystic carcinoma, pleomorphic adenoma, some myoepithelial carcinomas, and mostly basal cell neoplasms. Essential features according to WHO classification, the multinodular invasive growth, at least partly with the dual arrangement, as I was telling over and over, inner ductal and outer myoepithelial cells. And at least in selected cases, if we have the facilities, HRAS mutation can be helpful in differentiating other mimics. Okay, case number 6. This is a male time factor. This is a male patient of 55 years of age and the right parotid mass. FNSC was pleomorphic adenoma. Here the very basophilic looking tumor with this view. Here you can see the tumor with one part of the tumor is more eosinophilic and the other part is slightly more basophilic. Excuse me. You can see some spaces with eosinophilic secretions there, the common. And the nuclear morphology is very roundish nuclear morphology, and they're uniform, doesn't show much cellular ATP as such. But when you look at this area, this part of the tumor, you have these very marked secretions within. And when you look at the cells, these nuclei show some degree of ATP and the prominent nucleoli. Here again, the same thing, some degree of cellular ATP. And very occasional mitosis is seen. And when you come to this area, it has certainly more cellular ATP than the sections that we saw earlier. Here it is even more. Now you can see the cellular morphology is changing. Cellular morphology is not uniformly around this nuclei, but they are more becoming even spindly, right? The more hyperchromatic nuclei and very cellular, the cellularity has increased a lot. And when you look at here, you can appreciate the presence of mitosis, and cells are atypical and they have a significant amount of cytological ATP with prominent nucleoli. Here you can see these tumor islands are nipping into the adjacent tissue with small islands. S100 is positive. And the proliferation marker, the Chi67 or MIB1, we call, it's definitely certainly more than 10% in this field. Now this field, it is much less. Now this is the area I showed at the first slides where there is no cellular ATP or roundish nuclei, but this is the area where I showed you significant cellular ATP. The proliferation index is much higher than the other area. That tells us that there is something happening in this salivary tumor. So when you have a is another negative, I think, for this kind of cellular morphology. Acinic cell is a very high possibility, but S100 is negative in that tumor. You can see S100 positive here. So in the context, we need to think of other tumors similar to acinic cell, like secretory carcinoma. And secretory carcinoma is consistently positive for the rearrangement of ETV6. So whether there is high-grade areas or low-grade areas, usually it is positive. Now this is a secretory carcinoma with high-grade transformation. Now this is again not a very old tumor, so they're described in recent years. And the high-grade transformation, remember, occurs in many salivary gland tumors like acinic, secretory, adenocytic, epithelial, mucoepidermoid, I showed you earlier, polymorphous, and clear cell carcinoma. These, if you see unusual features that does not fit into a labeled salivary gland tumor, you need to think of high-grade transformation or carcinoma arising in a pleomorphic adenoma. Immunohistochemistry is characteristic for this. Of course, CK7 is positive in all other salivary tumors. S100 or SOX10 positivity is very important to differentiate it from, especially S100 positivity is important to differentiate it from acinic cell carcinoma, right? And mammoglobin is the more important marker, which is positive in secretory carcinoma. Now, if you have facilities, you can do things like DOG1, because DOG1 is negative, DOG1 is positive in acinic cell, and NR4A3, the molecular change. Now we have antibody for NR4A3, so they are negative together with the P63 and P40 are negative in secretory carcinoma. So if you have a tumor looking like acinic, but it is S100 positive and mammoglobin positive, and ETV6 rearrangement is there, it is a definite case of secretory carcinoma. Okay, the case number 7, interesting case, the 56-year-old man. I'm looking at the time all the time because it need to be on time. Case 7, 56-year-old man with a buccal mucosal lump. Here you can see normal mucous salivary glands and a tumor almost hugging the epithelium. Right, so the tumor has come very close to the epithelium. And unlike some of the tumors that we saw earlier, now you can see this tumor is very diffusely arranged cells and thin strands and also small ductal structures. You can see, you can appreciate numerous small ductal structures with secretions within that, right? So these are the normal salivary gland. So there's no drastic infiltration as such, but you can see it's going into the minor salivary gland tumor in places. Here, very myxoidy look in some areas. And certainly we can see the periphery of the tumor is extending into the other areas. Now, when you look at the cellular details, it's very clear the cells, some cells are polygonal, some cells are spindly, and in between, and you have tiny ductal structures. Now, characteristic feature of this tumor is these ductal structures contain not eosinophilic secretions, but basophilic secretions. As opposed to the eosinophilic secretions that we saw in secretory carcinoma. Here we have basophilic secretions. They are not large. And numerous ductal structures with the basophilic secretions within them. Here, it's very characteristic appearance of this particular tumor. So you can see in between the tumor island, this spindly stroma going, looking like slightly myxoidy as well. If you're not sure it is of salivary origin, here is the evidence. CK7 is positive, and P60 is positive in a significant population of cells. You can see P60 is usually internal control, is positive in basal cells. S100 is positive. SOX10 again is positive. So the immunohistochemistry is positive for S100, P60, and SOX10. Negative for P40 and mammoglobin. That tells us mammoglobin negative. It is not secretory. Of course, it doesn't look like secretory. As I told you, in secretory carcinoma, you get eosinophilic secretions. Here, they are more basophilic secretions. So this is a nice case of microsecretory adenocarcinoma. So these are the principal features. So we looked at them, microcystic tubules and bluish or basophilic secretion. That's a very important diagnostic clue. Nuclei are hyperchromatic, I showed you. They can be round oval, and you have the myxoidy or fibromyxoidy to basophilic matrix like we saw in this tumor. It is circumscribed, but not it is unencapsulated. I showed you areas of tumor nipping into the adjacent area with subtle infiltrative edges. Perineal invasion, although common in a lot of salivary tumors, is unusual, and also the lymphovascular invasion is unlikely. So the differential diagnosis is secretory carcinoma. It's not a big differential diagnosis, so we can differentiate. There are differential features. Polymorphous adenocarcinoma, yes, some areas of polymorphous adenocarcinoma can look like microsecretory carcinoma. Adenocystic carcinoma, yes, in some instances, the tubular, the trabecular type can look like the microsecretory carcinoma. And the other new entity that was included this time in the malignant secretory sclerosing microcystic adenocarcinoma, that can be a differential diagnosis in some instances. I will, if I have time, I will try to show you a case of that as well. Okay, the case number 8. I think I have a little more than half an hour to complete some more cases. And case number 8, it's a 2 centimeter swelling of the right lip, asymptomatic. It's a solid, well-circumscribed lesion, and the clinical diagnosis with is a fibrous mucocele. Now, remember, as a rule of thumb, when you see a swelling in the upper lip, if you think it is a salivary lesion, chances of that being a neoplastic are much higher compared to lower lip, right? Lower lip, chances of it being a mucocele, reactive salivary thing is much higher. Right, here, again, a tumor. So you have a lot of ductal areas, luminal areas, with papillary configuration in areas here, looking like slight hint of polymorphous or acinic cell carcinoma-like appearance. Here again, you have large ductal spaces containing a lot of secretions. Here, the cells with tiny papillary structures looking like what we see in papillary cystic salivary carcinoma, very similar to that. So you have some areas looking like intercalated duct type of cells, and again you have secretion, you have fibrovascular areas in between tumor islands. And again, when you do your common mark cytokeratin 7, that is positive, and S100 is positive. I showed you significant number of tumors, S100 positive. I'm showing this S100 in instances where it gives a diagnostic clue. Now this tumor this is a recurrent tumor in July 2019. You have to excuse me for the time because battery is running flat. I need to plug it. And July 2019, it was diagnosed as papillary cyst adenoma, the benign diagnosis arising from minor salivary glands. And it was said future clinical behavior difficult to predict, exercise in the event of recurrence of clinical suspicion. So that's from elsewhere. And cytokeratin. And in 2010, now this tumor was diagnosed as, earlier we have a diagnosis of cyst adenoma, now as actinic cell carcinoma. 2010, yes, it looks like actinic cell because you see these cells with very uniform nuclei and very eosinophilic cytoplasm and eosinophilic secretions containing. So you have similar secretions in actinic cell carcinoma as well as in secretory carcinoma. Here you have a lot of secretions and a lot of papillary configurations surface in these dilated areas. And in May 2020, now the recurrent, another recurrence, and then this tumor was a difficult one and differential diagnosis because it had papillary cystic areas, solid areas, and whether it's adenocarcinoma, papillary cystic, because earlier we had a diagnosis of papillary cyst adenoma, whether it's a papillary cyst adenocarcinoma or secretory carcinoma. Now, ETV6 rearrangement was performed, that was positive, and 2 further resections were done, and no recurrence since 2020. And this was with the ETV6 rearrangement was diagnosed as secretory carcinoma at the end. And the immunohistochemistry, earlier also I told you the cytokeratin, of course, CK7 is positive, S100 positive, and the hemoglobin. So if you don't need all the antibodies, if you have hemoglobin positivity and S100 positivity, even hemoglobin positivity with the correct histopathological features, we can be sure it is a secretory carcinoma because not other cellular tumors are positive for hemoglobin. And it is negative for the markers for actinic cell carcinoma. Secretory carcinoma, the WHO essential features to diagnose are single cell type with vacuolated colloid-like secretory material. I showed you that over and over. No cymogen cytoplasmic granules. Actually, something that I forgot to tell you is now, before the description of secretory carcinoma, these salivary tumors should have been diagnosed as something else, right? It was diagnosed as mostly secretory the actinic cell carcinoma. So then, when those days, of course, as I told you, the specialist strains played a bigger role. We know in actinic cell carcinoma, the cymogen granules are very dominant. Now, secretory carcinoma, there are no cymogen granules, right? So those days, I remember people diagnosing the things called actinic cell carcinoma, cymogen granule negative actinic cell carcinoma. But we know now they are not actinic, they are the secretory carcinomas. It is desirable provided you have facilities to do ETV6 or the right rearrangement. So that's helpful, but those things are not available in our part of the world mostly. Right, case number 9. I need to go a little fast, otherwise I can't complete the whole set. Case number 9, nodular submucosal mass in the left retromolar trigone. What you can see is the surface epithelium. Surface epithelium, and you can see again some ductal differentiation, and some of them vaguely look like, even with this power, bilayered and very basophilic tumor, right? It's very basophilic, and you can see some spaces looking like more cribriformy looking appearance. The excision, And here there's some bilayered structures definite, containing secretions, and some tubular and also slightly trabecular looking arrangement here and there. Here it is more characteristic, so you have classic cribriform look, and the tumor is infiltrating into adjacent area, and a lot of hyalinization, another characteristic feature of this tumor. Now, this is not a difficult diagnosis for you all. I think you can see proper cribriform areas in this area, the slide. Here the tumor, invasive tumor, is a high-grade tumor. There is no doubt because it goes into muscle. Here again, a very basophilic-looking tumor. One of the common features in this particular tumor is the presence of perineural invasion. You see, it is more than almost all the circumference of the nerve is surrounded by tumor. So that's proper perineural invasion. So this particular tumor produces neurotropic substances. That's why characteristically this tumor shows more perineural invasion. And again, you can see the tubular areas, more ductal areas, more cribriform looking areas, and the tumor is infiltrating into normal mucous salivary glands. Here again, very characteristic cribriform areas and also tubulotrabecular areas intermingled with cribriform areas. So diagnosis is not difficult. This is a case of adenocystic carcinoma. Remember, adenocarcinoma, cystic carcinoma is probably the second most common salivary gland tumor. So you got to be careful because sometimes pleomorphic adenoma and polymorphous adenocarcinoma can be challenging differential diagnosis for adenocystic carcinoma, not in all cases, but in some cases. But high end of the adenocystic carcinoma, the solid type adenocystic carcinoma, has a very dismal prognosis. Case number 10 is again elderly, the female patient, presented with a post-auricular lesion for many years, and diagnosis, clinical diagnosis was sebaceous cyst. Here you can see a tumor in a large cystic looking space, and the tumor is growing into that, and you can see the adjacent parotid tissue. So this is not from the skin, so it's probably arising from the parotid gland. Here, it's characteristic now, little reminiscent of normal salivary gland look. You see the basophilic cells with large cells with a lot of basophilic cytoplasm. And areas you can see vacuolation. Now this is, if you see vacuolations like this in a salivary tumor, this is one of the tumors which should come first in the differential diagnosis. You see the vacuolations. And when you look at the cells, cells have granular looking cytoplasm, basophilic, and the nuclear morphology is very uniform, very round, uniform nuclei in these basophilic cells with basophilic cytoplasm, and a lot of vacuolations, right? When you do the mucin stain, the DPAS, you see a lot of cytoplasmic positivity in these cells, the granular positivity in cytoplasm, right? It contains positive granules. S100, it's negative, right? S100 is mostly negative. So this is DOG1, right? So when you have a S100 negative DOG1 positive tumor and with a lot of vacuolations, round nuclei, more basophilic looking cells, so that the diagnosis is not going to be difficult. But remember, DOG1 positivity can be positive in some other salivary tumors, but not in this context. Chi67, yes, slightly, I think more than 10% of the cells are positive for proliferation marker Chi67, and there's a case of actinic cell carcinoma. As I said earlier, remember when you see a tumor with a round, very uniform looking nuclei, looking like sometimes normal salivary acini, and the cyanogen granules are positive in your special stain, and S100 negative and DOG1 positive, so it should be a case of actinic cell carcinoma. Now remember, actinic cell carcinoma has different types, the solid type, some tumors with lymphoid, very rich lymphoid stroma, and some tumors very much looking like intercalated duct type. So the many different types, presentations of actinic cell carcinoma. Remember that can be challenging sometimes. So the SOX10 and DOG1 is positive, although S100 is definitely negative in these things, and negative for P40 and P63 as well. The focal positivity of S100 in focal intercalated duct cells should not be taken as a diagnostic clue. So usually S100 is negative. Now, molecular markers have been described. I told you earlier, NR4A3, because the NR4A family, 1, 2, 3, all can be positive depending on the tumor, but NR4A3 is the common one. So we have an immunohistochemical mark for that as well. So that makes our life as pathologist easier. Case number 11. 60, you see the time? 63-year-old man presented with a swelling in the pituitary gland with facial nerve palsy. Now, with the history, you know, facial gland, the palsy is associated with salivary tumors, mostly adenocytic carcinomas in the context. So we know this is going to be a malignant salivary gland tumor. So other malignant salivary gland tumors also can have perineal invasion giving rise to facial nerve palsy. But adenocytic carcinoma is the notorious one. So here is the tumor. Normal salivary gland is going into normal salivary gland diffusely. In this power, we can see the salivary tumor, nasty looking tumor going in between the stromal collagen, invading. Here you can see the probably the fatty tissue around pituitary gland and the normal atrophic salivary tissue. And away from that, you can see an island of tumor, roundish, and central area probably having comedotype necrosis. Yes, you can see characteristic comedotype necrosis in almost all tumor islands. Now we know comedonecrosis is not just in one tumor type. So there are in most high-grade tumors. That happens because the tumor is growing very fast, proliferating very fast. The central cells are going to be devoid of oxygen because of the growth rate. The angiogenesis is not comparable with that. So the central cells undergo necrosis. That is the reason why we get comedonecrosis, but it is characteristic for some of the tumors. This is one of them. And you can see these cells with a certain degree of cellular atypia and ductal differentiation, and big nerve having perineural invasion. Again, very prominent comedotype necrosis. And you can see within this tumor island some cribriform looking areas. And more characteristically, when you look at here, you can see the cribriform look and also these two cystic areas separated by a bridge, right? So this in pathology, we call it Roman bridge appearance. I don't know why. So this is characteristic for this particular tumor. You see a lot of necrotic the areas at the center. Now, sometimes this tumor can be difficult to decide whether it is a salivary tumor or not. When you throw a CK7, it's positive. And if you do this particular antibody, that's very helpful in diagnostic of this particular tumor, the androgen receptors. You can see androgen receptor nuclear positivity is very strongly positive in this tumor. Chi67 is very high. So that tells us we don't need Chi67 to say this is a high-grade tumor with the type of comedonecrosis, perineural invasion that we realize in this tumor. So this is a characteristic classic salivary duct carcinoma. Not difficult. Your immunos are going to be helpful. You don't need many. You can have your androgen receptor in the context. So then we know you are looking at a salivary duct carcinoma. Again, similar to other salivary tumors that we discussed, there are subtypes. So that is where you find difficult to diagnose. You can have sometimes very spindly looking cells showing sarcomatoid differentiation. You can have mucin-rich. You can have micropapillary. You can have basal cell-like appearance in some salivary ducts, oncocytic variant. And of course, to make it life even difficult, sometimes salivary duct carcinoma can undergo rhabdoid differentiation. Molecular ERRB2 amplification and also mutations in some other the oncogenic genes like PIK3CA and also P10 loss is a feature in a subset of salivary duct carcinomas. Case number 12, 65-year-old female with a pituitary tail lump. So clinical diagnosis, whether it's a pleomorphic adenoma, we know whenever you have a tumor in the pituitary gland, pleomorphic adenoma is high up in the differential diagnosis because 80% of pituitary lumps, remember, are pleomorphic adenomas. That tells you, even without looking under the microscope, 80% of the time you can say it's a pleomorphic adenoma. So very nice characteristic looking tumor. You can see the tumor island separated by some eosinophilic looking membrane, the hyalinized membrane. And tumor is more circumscribed. You can see some tumor islands breaking away from the tumor, right? Now, very basaloid look in some areas, slightly high power. So you can see basaloid tumor islands separated by basement membrane material, hyalinized material, and the periphery of the tumor. When you look, you can see these small tumor islands breaking away from the main tumor. Some parts can, in this particular slide, have slightly clear cell differentiation as well. And these tumor islands are more basaloid in some areas and separated by this hyaline membrane. Here is the characteristic, the classic appearance of this tumor. Not much of cellular atypia in most tumor islands in this particular tumor. But one feature that you need to appreciate is that some of these tumor islands are breaking away from the main tumor and going into the surrounding area. Basaloid looking tumor islands. The same thing, you see, this is what I said. Now, these are the main tumor islands and these are breaking away from the main tumor. So that invasive pattern is very important to diagnose this tumor. Here, it is going into peripatetic fat. So that's very characteristic because this is very important, especially when it comes to FNA diagnosis. This tumor can be difficult. I'll come to that later. Again, here you can see the some of the structures, I mean bilayered structures. I told you the list of tumors that you have bilayered ducts, bilayered appearance, pleomorphic adenoma, adenocystic carcinoma, sometimes myoepithelial, and also basal cell adenoma and basal cell adenocarcinoma. Can it be one of these? So CK7, yes, it confirms us it's salivary, and S100, yes, S100 is slightly positive. There's in some tumor islands, and P63 is very significantly positive. Now, this is a case of basal cell adenocarcinoma, right? So epithelial myoepithelial markers are positive, and this tells us the dual cell composition. I told you over and over. And another important antibody that is going to help you is the beta-catenin, right? Beta-catenin is positive in some difficult cases, and more importantly, in a subset of cases where it doesn't look like basal cell. You can do beta-catenin. It can be helpful sometimes. Now, what I want to tell you earlier is now basal cell adenocarcinoma, we know when it is parotid, of course, the first line of investigation is FNAC. When you have FNAC of a basal cell adenocarcinoma, it's very difficult to say whether it is malignant or benign. All what you see is basal cells, right? So differentiating it from basal cell adenoma is next to impossible. It's very similar to the thyroid follicular neoplasms, you know. So you need to see vascular and capsular invasion to make sure that it is a follicular carcinoma, not adenoma. Similarly here, you need to see that invasive pattern that I showed you earlier, tumor islands breaking away from the main tumor and going into surrounding area. So that we cannot see in FNAC. So we usually in FNAC call it basal cell neoplasm. So that's something that you've got to remember. But some basal cell adenocarcinomas are high grade. That's not a difficult diagnosis, right? So adenocystic carcinoma can be a very challenging differential sometimes, especially when you have this trabecular pattern. But classic basal cell adenocarcinomas is not difficult to diagnose, but sometimes basal cell adenoma can be a challenging thing. Now you need to remember basal adenoma has different subtypes, the tubulotrabecular solid type, membranous type, etc. The membranous type has a high chance of malignant transformation. Now this, I showed you a lot of membranous areas. Molecular, if you have facilities, now most of these basal adenocarcinomas are positive for CYLD or CTNNB1, the beta-catenin family gene that is altered in basal cell adenocarcinoma. We have a few more minutes, I think. I try to cover a few more cases. Case number 13, 65-year-old known case of female of known case of breast cancer. Now presenting as a non-healing ulcer at the floor of the mouth. You see the very significant enlargement of the jaw in that area. You can see a very nasty looking tumor and very nasty looking tumor destroying the mandible. Here the tumor cells are arranged like more like an organoid pattern, and the cells show some degree of cellular atypia. You can see occasional cells are looking very pleomorphic. Here the mitosis and certainly high degree of cellular pleomorphism in some of the cells, and slight hint of slight epidermoid looking cells. Here again, the same picture with some degree of cellular pleomorphism and mitotic figures here and there. And very characteristic, there's a nerve here, and there is perineural invasion. That tells us this is a high-grade tumor. Another nerve with some tumor cells around that. Immunohistochemistry of this particular case, CK7 positive, P63 positive, S100 was negative, and P30 positive, and there is a very high proliferation index. The whole range of markers are positive, the negative and the positive markers were P63, P40, and CK7, and you can see Ki67 is very high in the particular tumor. And you can see some of the features, high-grade cellular atypia, and PS is positive in significant number of cells. And this is a case of high-grade mucoepidermoid carcinoma. Because of the time factor, I can't explain the features in detail. Case number 14, because there are some interesting cases, I want to get into those things. Case number 14, it's a 54-year-old female, known case of pleomorphic adenoma of the submandibular gland, and surgical removal done a significant number of years ago. Now, the question mark whether it's a recurrent pleomorphic adenoma of left submandibular gland. Here the previous mark of surgery, now it's presenting as a recurrence. Okay, it doesn't look like pleomorphic adenoma on this part. So surface epithelium and the tumor cells, more basophilic looking tumor cells. Here the tumor cells have spindly appearance in some areas, but more polygonal cells in some other areas, and slightly hyperchromatic cells, the nuclei, and some cells having clear cytoplasm looking like little myoepithelia. Here, more clear cells, spindly looking. Now remember, myoepithelial cells can have spindle appearance, complete spindle appearance sometimes. Now, very clear cytoplasm, suggesting us whether they are myoepithelial cells with the previous history of pleomorphic adenoma also, and some hyalinization in between. And P63 is highly positive in the tumor. SMA is focally positive, and GFAP is focally positive. P63 is also focally positive. And this is a case of carcinoma arising in the previous pleomorphic adenoma, more towards myoepithelial carcinoma-like differentiation. I showed you this area, this line is more looking like myoepithelial cells. Now, CXPA, you've got to remember the carcinoma component can be very many salivary gland tumors. Now, with my experience, our experience, one of the commonest type is epithelial, myoepithelial, and myoepithelial. So they are the two common things. But when you look at the literature, the commonest type is salivary duct carcinoma, but that's not the experience with our experience. You can get adenocarcinoma in noise-looking areas, but overall, epithelial, myoepithelial, and salivary duct and endocarcinoma NOS are the common lines of differentiation when you have a pleomorphic adenoma transforming into CXPA. Now, remember, when a pleomorphic adenoma recurs several times, the chances of that transforming into CXPA is higher, and also the long-standing pleomorphic adenomas have a high chance of transmission as well. Case number 15, 59-year-old patient. Now this tumor initially present as a swelling and ulcer. Patient has here the surface epithelium, and you have a tumor with a lot of ductal differentiation and diffusely infiltrating the underlying corium. Here you can see the tumor with nondescript tumor cells with some cribriform look in some areas, but a lot of ductal differentiation. And perhaps some areas with mild necrosis. Here, when you look at this, it's very difficult to attribute to a particular described type of salivary tumor, but you have ductal differentiation and some solid tumor islands here and there. Again, ductal differentiation, solid tumor islands, and slightly spindly shape in this area, And in some tumor islands, you can see there is hyperchromatic nuclei. So if you ask me whether we can label this into a very definite described tumor entity, it's difficult. It's positive for cytokeratins, even for 5-6 focally, and negative for a whole range of other antibodies, right? Because we need these kind of antibodies in this because, as I said earlier, the tumor islands or the tumor characteristics, the cellular features are not pathognomonic for a definite histopathologically described salivary tumor. P63 is focally positive, very focally, but it's mostly negative. And CK56 is positive, suggesting some degree of squamous differentiation, and CK7 is positive, and CK20 is negative. So that exclude met from different areas. So this is adenocarcinoma. NO is high grade. You remember in the previous classification, we had adenocarcinoma. NO is having a lot of entities. We have papillary cyst adenocarcinoma, even mucinous cyst adenocarcinoma. But now we have separated them out. Mucinous cyst adenocarcinoma is taken out from that, and it goes as a separate entity. But papillary cyst adenocarcinoma is still bundled inside this adenocarcinoma NOS. Right, salivary gland adenocarcinoma NOS, that is what we said in the present classification. It's a heterogeneous group of tumors forming epithelial, ductal, and glandular structures, but we cannot label it as a definite salivary gland entity. Then you put the label as adenocarcinoma NOS. So salivary gland carcinoma NOS in the latest classification. Immunohistochemistry is helpful to distinguish that from known entities like acinic cell, the myoepithelial, vessel cell, etc. Also, metastatic adenocarcinoma is something that you've got to remember. Once you exclude all those things with known immunohistochemical stains, now you are left with the diagnosis of adenocarcinoma NOS. We'll finish with this case, although I have a few more cases. This is a 72-year-old the patient. Again, history of pleomorphic adenoma, and so the nasty looking tumor, and the tumor extending into eye, giving rise to blurred vision. Clinical diagnosis, recurrent pleomorphic adenoma. Now you can see it doesn't look like a friendly tumor, so it's involved in the total eye. You need to remember you can get pleomorphic adenoma in lacrimal glands as well. Now, when you look at here, it doesn't look like a pleomorphic adenoma at all, but still you have bilayered structures having tumor cells very nondescript. Some tumor cells have hyperchromatic nuclei, and ductal differentiation is very prominent. And here, again, the cells are difficult to convince ourselves as pleomorphic adenoma, but it has a certain degree of pleomorphism. Here, the outer cells showing clear cytoplasm that tells us they are myoepithelial in origin, and the tumor has certain degree of cellular and nuclear pleomorphism, unlike pleomorphic adenoma. Now we don't have the stromal component to suggest that it's pleomorphic adenoma. With the pleomorphic adenoma, you know that to diagnose it, we need to have the epithelial component as well as the stromal. Now here we don't have the correct stromal component for a pleomorphic adenoma, but here the cells showing definite myoepithelial cells, outer clear cells, and we have the proliferating inner epithelial cells as well. Again, here the same picture, certain degree of nuclear and cellular pleomorphism. And the immunohistochemical stains are positive for P63, P40, and S100, and also the EMA and CA in some, and CD117 is positive in some areas. Remember, CD117 is a diagnostic marker we use for adenocystic, but it doesn't mean that it is positive only in that. It's positive in a significant number of polymorphous adenocarcinoma, around about almost 60% or more. So therefore, you have to interpret CD117 in the context. So this, we know it's not a pleomorphic adenoma, it is definitely undergoing malignant transformation, CXPA with epithelial, myoepithelial like differentiation. As I told you, in our experience, this is one of the common line of differentiation for CXPA. I will go into this case because this is something that you may not have seen. This is a 55-year-old male presenting with a right buccal mucosal lesion. And you see it is more like a surface epithelial lesion having papillary projections and basaloid in appearance. You can see some ductal differentiation there. Very marked papillary configuration looking like basaloid in appearance. So these are very rare salivary tumor. But there's some doubtful arguments whether it is salivary in origin or otherwise. And you see very prominent papillary structures with more spindly looking arrangement. And you have a fibrovascular coli similar to our squamous papillomas in these cases. Here you have the ductal differentiation in areas. We have more columnar cells towards in some of the papillary projections, very columnar looking cells with some very ciliated surface as well. So this the classic textbook picture of sialar adenoma papilliferum, right? So it's a diagnosis that you don't miss if you have seen this once in your life. Sialar adenoma papilliferum is typically polypoid with a papillary surface with well circumscribed margins. The size is important. They usually don't go more than 1 centimeter in size. The cystic spaces are very visible when you do processing of this case. And remember, this case, unlike other salivary tumors, is positive for BRAF V600D mutation. So it's unusual, but it is the case in this tumor. But it's positive for other salivary markers like CK7, etc., but not to the extent that we see in other salivary gland tumors. Basal cells, of course, are positive for P63. So this is a very nice example of this particular tumor. With that, I think I will stop because of the time factor. So it's a case of adenocystic carcinoma, hybrid transformation. I would like to acknowledge my friends who provided some of these cases. Not all cases are my cases. And my dear friends, thank you very much for listening. So I will come live to answer some of your questions. Again, my Pakistani friends, now this is the second time I meet you in Pakistan after that meeting last week. Thank you very much.
Thank you very much, Professor Savikatne. And we have Professor with us live for all your questions. Hi, Prof. Hi, Prof. Hope you're well. Can you hear us well? You might have to unmute the mics. हमारी तरफ से तो mute नहीं किया।
Sorry, I'm unmuted now.
Thank you, Dr. Philipson, for such a insightful talk. And I assure you that salivary gland tumors are always very tricky, and especially because we get both FNAs and biopsies along with excision. So it gets very tricky to diagnose them with the limited immunohistochemical panel that we have. So I have some online questions. In your experience, can more than one malignancies arise from pleomorphic adenoma at the same time?
Yes, it's a good question. Now, when pleomorphic adenoma turn into carcinoma arising in PA, according to literature, if you look at, it says salivary duct carcinoma is the commonest line of differentiation. But that is not the case with our experience. My experience, they are mostly epithelial, myoepithelial or myoepithelial differentiation. But you can in the same tumor, sometimes you can have different salivary malignancies in a CXPA. You can have salivary duct carcinoma, you can have mucoep looking like areas, epithelial myoepithelial or myoepithelial, you can get a combination. Sometimes even adenocystic. Sometimes you get only one type of tumor. So that is where you sometimes struggle if you don't have the clinical history, whether it is de novo salivary gland malignancy or carcinoma arising. So that is why at the beginning I said sometimes clinical information is important. This is one of those tumors where clinical information is important. Yes, this CXPA, you can have different lines of differentiation, but in my practice, what I call is, if I see salivary duct carcinoma like differentiation, I don't call it salivary duct carcinoma, I call it CXPA with salivary duct carcinoma differentiation, and so on. Hope I answered your question.
Yes, thank you very much.
It is noisy. I can hear somebody speaking as well.
Are you hearing our echo maybe?
Now I think it's clear. Otherwise, no,
Next,
still I hear some noise.
can you hear me clearly now? Can you hear my voice clearly?
Yeah, now it is better.
Right. Next question is adenoid cystic carcinoma. Can adenoid cystic carcinoma arise in a pleomorphic adenoma?
Yeah, I think I answered to that question. Whenever you get a salivary malignancy, features of another salivary malignancy in a pleomorphic adenoma, we don't call it anymore pleomorphic adenoma. We call it carcinoma arising in pleomorphic adenoma. Yes, adenoid cystic carcinoma line is one of those. So we can get adenoid cystic carcinoma developing in a pleomorphic adenoma. Then we call it CA, XPA with adenoid cystic carcinoma-like differentiation.
Right. Thank you. The last question is, what is the significance of grading the adenoid cystic carcinoma since all grades tend to behave aggressively?
Not really. Now, now salivary tumors, we have different classification gradients for different tumors. When it comes to adenocystic carcinoma, we have three different types, right? We have the fibriform type, we have the tubulotrabecular type, we have the solid type. Now, this histopathological differentiation itself gives the prognosis. Fibriform has the best prognosis, then tubulotrabecule, and the solid type has the worst prognosis. Solid type adenocystic carcinoma, not easy to diagnose. There's a big difference in diagnosis with other basaloid malignancies, and even sometimes with blue cell tumors. And it has a dismal prognosis. Yes, therefore, the just calling adenocystic may not be enough. So one has to decide whether it is tubulotrabecular, fibriform, or solid. Not more often than not, you get tubulotrabecular and fibriform in combination.
Thank you. Excellent. Thank you. Thank you so much, Prof. Tilakratne. This was an excellent presentation. And thank you for answering all our questions as well. Hope to see you tomorrow again for your talk tomorrow on oral cancers. And,
Yeah, sure.
all right.
Thank you very much.
For your time. Thank you. So this was Professor Tilakratne, and now we will have a half-hour lunch break, and we'll see you again here at 2 p.m. sharp. Thank you.
मैंने किया
People money चलते ही बनता वो जायद वाला मस्का
के वास्ते ये ठीक है उसको
है ना
कॉलेज में
हेलो
ठीक है ये अच्छा है ये चार्जेबल है
हेलो हेलो हेलो
पहले अपने पहले ज्यादा होगा
नहीं ये बात ये बात हेलो
ये ठीक उसको मान लीजिए
इसको बांधने
इंस्ट्रक्शन भी करते हैं
हेलो ये भी चलेगा और करता रहेगा
बस पहले आपको पहले उनके लास्ट दो सर्टन मैंने चार सर्टन
बस ये आपको लास्ट
जो एस्केबिलिटी it is like we
हाँ शुरू से शुरू करवा
PowerPoint पे
ये वीडियो ये ओपन
ये
पड़ी।
सी
हाँ ये किसी की बस सिंपल जब शेयर करवाना है हमने यहाँ से इसको शेयर करवाना है, करवाएंगे तो वो उधर से वो आ जाएगा। अभी तो उधर से वो पैनलिस्ट बनाओगे
ये पहले से पहले
नहीं अभी नहीं है। ये देखो ना,
अपने डेज के
ये देखो
अब पहले से नया पे मोबाइल
पार्टिसिपेंट भी क्लिक करें ना। लिस्ट में इसका नाम क्या है? सिम्पोजियम 1
नहीं नहीं इसका नाम
यही है ना।
इसका नाम ये मोहम्मद सुहेल।
तो पैनलिस्ट में ही है ना मोहम्मद सुहेल।
3 पैनलिस्ट है।
हाँ।
ये क्या है?
You request multiple presenter sharing for this webinar.
उधर से आनी है
पहले से
हैं?
पहले से
इसको एक बार नंबर पे बात करना।
ये जब हम बताएंगे तो फिर ही तो शेयर होगा।
अंजलि की
बैनर हम बताएंगे।
हाँ मैंने
This isn't really quite into the whole stuff. Almost have like a glass cycle is places, almost like a wrapper appearance or sphere as well, but they're not giving a lot of it. Here you can see a little bit more plasma wrapper, almost look quite far, with some in places, but there really is slightly more granular. But then also like sheets of these, is there a second before? And that seems to be the similar pattern that's going throughout the material. So the first thing is to establish the possible dialogue of human is so we can see the site in the many pictures of 720 was there, then also negative 10 back on 2 and secret 14. It's also negative for neuroendocrine markers as well. Talk about metastasis from prostate, that's also negative. But A1, A3 was usually positive, so it looks like that will be carcinoma. ECTP was also usually positive. And then this, any guesses about what this marker might be? You can see it's positive in the stroma, that is negative in the stroma. Sorry, someone said something. I don't know, that's what we, this is INI. So INI patient is lost in the tumor, even though it's positive in the stroma. slightly functioning, you know.
I go to the time and try changing. Why did it scan?
Slide change. Should I just show this? And it's very important to know about although they look like some of them didn't find the relevant and negative for those. It's very important because the diagnosis is right, because that's a high grade determinant very aggressive into the area. And most patients unfortunately will present with the ego disease. This is a case of 45-year-old female who can be diagnosed with a lesion of the right thumb. You can see it looks quite nodular, almost gives you an impression of fragile granuloma. Then a epithelial coverage on this side, but the rest of it looks like it's saturated, particularly on that aspect. And as you look closer, it looks like it's largely comprising these spindle cells. Self-visibly is also very here. And as you zoom in, then you can see there's a lot of polymorphism in the spindle cells. You can see those large hyperchromatic nuclei. And again, you can see some more of some of them need to look like the multi-nucleated, like into clearing as well. No obvious evidence of differentiation of any sort. As peritology looks a little bit thick and almost like raw peach like, but you still have those sort of big multi-nucleated spindle cells. But towards one aspect of the surface area, you can see that there's obvious display here as well. So the leaking process is back down, then you can see this quite a lot of polymorphism and this disorder stratification. With the stromal cells, phytoplankton was negative. That's not the SMA also negative. You can see 34 designated one also negative. 81, 83 highlighted some of those large multi-nucleated cells, you can see. But the majority of the spindle cells are negative. P63 was better earlier, so it was also describing that the last because of the breast, and it can work quite well in case of the cytokine doesn't work out. In my experience, it doesn't for more fully differentiated squares and carcinomas. And CD138 can be quite well for actually this modules. Then you can see P63 is involved in quite a wide proportion of these cells. But I think it's one of those families that never use the word never tell you anything in the head and neck because everything is positive, but now this is not anything that's positive throughout. And this is usually very, very clinical patient. In the sarcoma, sarcoma, SCC, as I said, high-grade lesions, cytokines are negative, a lot of these was always in a combination with P63. And my experience, technology is very, very useful and helpful. This is quite an interesting case from 51-year-old male who was under the lung in the left carotid. So first class, there's a carotid issue there, right carotid lymph node, and there's humor of some sort. It looks like well defined circumscribed, although divided in the nodule which is coming upwards. And you have a closer look, it's quite a bad line appearance. And also a real prominent cystic change. Slightly sort of people secretions there as well. Not seeing any convincing ductal areas, but a suggestion of like some capillary structures. I'm not sure how real they are. But the cells look very loose from the side, looks like the angular also into a purely form appearance like that in a 60 carcinoma and places as well. And on four biopsies was diagnosed as an diagnostic carcinoma, and this is the spinal dissection. There was negative for CK7, CK20, and also negative for all of these other markers. So many ideas or cases which should be good. Looking at the morphology. sorry, carcinoma or some sort is not salivary. So cytosol 5, 6 is positive, of course, that you can see. That's also highlighting the external extension of the tumor is also extending to the surrounding part. P63 is also continuously positive. GNA was negative, and it was very before positive to all the different. So this was a case of metastatic basal cell carcinoma. Very rare, and when I first made the diagnosis, I was checked by the family, but then we found out that the patient had had an incision somewhere else 2 years ago, and oncology became managed this one as well. But it's extremely difficult, 0.002% of these metastasize. It's so rare that we managed to publish it as well. Case 4 is from a 76-year-old male presented with a right maxillary swelling. Looks somewhat similar to the first case, so you can see bone, but bone normal architect has been disturbed and there's a lesion or something in there standing through it. Again, it's not getting a lot of it, but small cells. And some angiomas go like a signaling like where there's some clearing. Perhaps where there's just a little collection of cells, it's also values of the mental lymphoid tracts. But then as you start looking in the bone, there are like more of these islands which are they're somewhat squashed, but they seem to be extending into the bone as well. Once you identify these, you can see that they're extending actually a lot through the bone. So what they show whether this one positive side of keratin, which is actually carcinoma. And you can see quite diffusely positive extending throughout the maxillary bone. And yes, there was also diffusely positive in this one. The patient would know the patient didn't have a known history of prostate cancer. So it was the first sort of manifestation of it. But again, maxillary and mandibular, jawbone in particular are very common signs of metastasis from this size. So always keep that in mind, particularly it's not behaving and acting of those particular signs of evidence for market that you would expect. So just one example of this case in prostate selected as well. This question of washed out almost mucoid because it's quite prominent microcystic architecture. But these does look like they only got a single layer and not bilateral structures. And it's also quite common to epithelial crystalline phase on the surface as well. And again, the secretions within the ducts were quite bluish or mucoid. The strong slightly measured phase, but the most part was quite soft. So yeah, I also always use CK7 and 20 for salivary tumors. So you can see CK7 and it will be positive. Here, we get near the sample, but they're only positive in luminescence in this case. This is CAM5.2 of the highlighting with a single cell population. You can see all of the human carbon positive correlated. And there's also quite a large proportion of cells of EC3 positive. And we heard earlier about the phenotype of that EC3 positive and that's one and the positive. The volume of the carcinoma can be shown in the profile. But the morphology of this wasn't really getting up. The body was negative again, so which was good. But again, this thing could be about we just Bishop and we managed to publish this together in a series. And this case also showed that SSAT in gene fusion. The test is available because you want the sample sarcoma testing perhaps available, so if needed, you can do it. But I think that even the day we were discussing earlier, a lot of molecular testing is academic, perhaps because it's one side in the treatment of the patients. So morphology still is perhaps the most important thing to think about. So the important to remember is that the immune profile is similar to polymorphism and carcinoma morphology, just a bit different. This is another vision from the palace. And here you can see one normal tissue was the periphery, and then here, of course, well defined medium centrally. And as you look closer, the stroma is very, very colonized, very sclerotic. You look closer, there's quite prominent sort of background change in places. Here as well, you can see the sort of vertiform architecture, epicardial things. Some of the cells, also got these issues like granules in them. Here as well, because the base cell change too. And this was sent to me as a potential carcinoma experience, but there was quite a lot of basically some of the nuclei, shown some nucleus are a little bit more, some of the development from the ACI, it's called biological architecture. But the disease level was quite low, it looked like very well defined, and it looked like it was infiltrated, and you know you can get sometimes it can be benign, you know, melanoma as well. But the interesting thing about this, you know, the field volatility for androgen receptor, and also for TCP and P. So this is an example of the sclerosing polycystic adenoma. So this is a recently upgraded entity, which should be thought to be a reactive lesion sclerosing polycystic adenosis. But now we know that there's a further change in it and that it's a benign tumor. So quite rare, but once you've seen one, it always helps for identify the next one. This is sort of a 60-year-old density that was a well circumscribed lesion in the right rocket. You can see that it looks quite abundantly globular. There's a bit of background protein there. Then we show them a little bit, it looks very vascular, sort of chicken wire type of earrings. These fibers separating which are separating these clear cells, very, very commonly clear the nuclei and versus the substrate. It doesn't seem to be extending to the surrounding project. In one area, there is suspicion of vascular invasion as well. We heard about basal lesions, large tumors, pretty much all of them can show basal change. So the important thing is to think about what cell population there is a single cell population that we call whatever the myopathial cells. But this one didn't have any epidermoid mucus cells in it, so that was already epidermoid carcinoma. It could potentially be a semi-cell carcinoma, but the vascular background was very thick. And it was actually said to me as a potential epidermoid carcinoma. And then the other type of tumor that can also show basal change. Some of these, like a field myopathial carcinoma, will have luminal and abdominal cells. So this one was negative for 67, negative for 20, pretty much negative for most things that we saw earlier. That suggested we did this was not selective. And the only thing that came up positive was a RC. So this was a case of metastatic renal cell carcinoma in the patient. Didn't have a confirmed diagnosis of renal carcinoma. So they went back and they did a normal CT after I issued the report. And what they found was that there were renal marketing in both groups. So this was quite an interesting learning point. And again, showed you the example of importance of simple things like 5 values, 7 and 20, possible lenses, and that really has. This is again quite a rare case. This is an 11-year-old male patient presented with a cystic lesion all in the mandibles. We can look at the radiology a lot when it's the mandible, and you can see the lesion looks not very well defined, looks very extensor. Here you can't see the anterior wall of the mandible, it's something that's eroding the mandible. Those cells, it looks slightly parasitoid. Hopefully there's some hints of scaling as well. And then once you start seeing that, and you see more and more of that, quite prominent in there, but the cells will look more parasitoid than the other one you should buy. The cytokine 7 was positive, and the cytokine was this is not healthy because in terms of what it could be. P67 is quite low, so that is the low grade thing. And they can think about this. But there is a wide differential of these, of course. There is a case later on that I talk about some of your doctors have been that are worth considering as well. This perhaps some of those instances where molecular can be helpful, although most of these are very low grade. This is based on a 25-year-old female with 6 weeks postpartum lesion in that process. So she had a biopsy and it was diagnosed as large and carcinoma of some sort, but it's completely blown up in a few months, and now it's really large, and we're trying to people. You can see this, but cells by prominent necrosis, focal areas of clearing. And then I started picking up these very small areas which might be all little squamous or epidermoid appearance. And then started to see those more and more scattered throughout those cells. So the people who sent it to me thought about mucoepidermoid carcinoma with hybrid transformation. The CK7 was very vocal in it. Fish from mammal was also negative. We thought about something like neuroendocrine carcinoma. Again, it wasn't really staying like one. P63 and P40 were quite diffused, and interestingly, P16 was also positive in 30-40% of the cells. And then once the image was positive, diffusely throughout the tumor was not. So this was a case of a primary nut carcinoma on the prostate gland, and previously they used to be called midline carcinomas, but now we know they don't just involve the midline. They can basically involve any what figures that have neck, the polydifferentiated carcinomas, and you can get those focal areas of squamous differentiation, and then nothing rearrangement, but unfortunately they're very high grade lesions. And prognosis is quite poor, and unfortunately this patient also comes to very less than 6 months of diagnosis. Case number 9 is from an 83-year-old male patient. History is interesting. First is a history 2015 of an adenoid cystic carcinoma from the inferior turbinate. And then in 2018 biopsy shows vertical carcinoma. And now there's a subsequent biopsy which has been sent to me, and I follow up these one that doesn't do the same thing, or it's 2 different tumors. When you look at the histology, so there's the signs, there's the strategic lining of the surface. On this side, the tumor looks quite solid and basiloid. You can see those islands sort of extending towards this side as well as some more normal looking line. Quite prominent cribriform architecture, the Swiss leaf pattern that we associate with an cystic carcinoma. Obvious evidence of peripheral invasion as well. But then, as you start to move away from this, you start to see that the cells are becoming less differentiated. And in these areas, they are almost undifferentiated because they're just pleomorphic cells, just sheets and islands of them, and they were showing the same pattern as the polypical cribriform areas. Hopefully, there's a sort of characterization as well. So, quite an interesting geological divergent pattern of differentiation. So looking inside the dragon cell, you can see it's only opening positive and some of those solid looking islands. Whereas at the 5 and 6 one more positive, those fully differentiated potentially squamous looking areas. P63 positive in most of the tumor, and the pattern of resonance was slightly different than the more cystic like areas. It seemed to be more towards the periphery, whereas in the undifferentiated areas it was more scattered. And that's it was only seen in the so anytime you see an advanced cystic carcinoma like lesion in the side of the lesion, nature it will be 16, and B16 is 100% positive, start thinking about it. Why is it important? Because although these look aggressive, they are quite well delineated and treatment wise and prognosis wise could be very different in terms of what treatment for the patient. So originally it was described as an HPV related inflammatory carcinoma with very advanced display-like features. Possibilities were useful, and the interesting thing is that compared to oropharyngeal HPV carcinoma, this is largely related to HPV-33. So most of the cases are caused by HPV-33, but a small percentage can be caused by HPV-16 as well. But a lot of these are quite well related. So I'm very sure that if you relate to the 60 or that system. And the things that can help you differentiate, of course, B16 will be positive in these two. But then what tends to happen in this is 100% of the cells are positive. So that's quite useful because most of the HPV related ones might have block positivity in some sphere. In the left submandibular region, we're looking at a low power, you can see quite prominently cystic lesion, a lot of pulmonary secretions, but quite prominently lymphoid stroma as well. You saw an example of this in the previous picture. So this cystic various between in the epithelium is giving rise to the walking tumor. Suggestion it might be oncocytic in places. So most of it doesn't look like it's oncocytic. It's quite close epithelium, but looking around in the wall, there are areas which look almost squamous epithelium. You can see a proliferation of those within the lymphoid tissue. So PST in this case highlighted the cytologic mutation in some of those squamous looking islands. I don't think immunohistochemistry is helpful at all when you think about mucovagal carcinoma, that's mostly oncology or molecular testing. The TCC7 interesting was IH. That's can be quite difficult to determine that it was such a strong lymphoid infiltrate or some of these sites. But this one actually had mammoth rearrangement, so this was another example of a walk-in line mucovagal carcinoma. And looking at them side by side, you can immediately see the differences of the lining is different. You get the bilayer quite eosinophilic, oncocytic epithelium, whereas in this you can look at it mimics it, but it doesn't tend to have a true oncocytic change. And in addition, you'll see that the lymphoid present areas and also mucus cell areas. That's the problem. You can get anything mucus cell involved in the human too. But if something that's bilateral and it's largely oncocytic with focal lesion, is most likely to be born than a born likely birth is about carcinoma. Yes, so when I don't present image now, so this is a 50-year-old male with a lesion involving the left mandible. This is the panoramic radiographic section, and here's the lesion that we brought. You can see it's next to the roots of the teeth. It doesn't look very well defined. It looks like it's standing between the teeth. And when we see something like that, it doesn't have a clear border or a very free to it, we worry about it. That's some people label. And you can't tell much from histology at this level, but you go in a plate, you can see that there's islands of this of most squamous epithelium, if you like, this could be cellulose epithelium for static prosper. But then the other island you seem to be extending throughout the fibrous tissue. The stroma is quite fibrous, islandized. Hopefully, there is a suggestion of layering. The first thing I was thinking is this a place of non-rhodontic place with carcinoma, but this wasn't really showing a lot of pathologic layering for the stroma was islandized. But here you can see here side by side this This side here shows some clearing. On the right side, we're seeing more eosinophilic clearance. But actually, this did not need to use our really, but then the reason I wanted to show this example is that clear cell carcinoma does not always live, it might just be locally clear. And it might be similar case for thyroid, clear cell or visualized clear cell carcinoma as well. Although they tend to be more prominent in clear cell or okay. So this didn't very rare, was another case that we reported, and it's meant to be quite slow going, but it was losing routine. And what you get is these sort of regulated cells, what fibers of sclerotic stroma, either PSR one rearrangement, and most common partner ATF. But the important thing is if you get something like that, make sure that you've got a bit of tissue that you don't put or decalcify, so you can do if you want to do any molecular testing. So the definition for this is things like the non-genic fibroma, for example, can show similar sort of appearance, but you won't see any calcification in the case of the non-genic fibroma. Okay. We always look at radiology, and if you're not comfortable with radiology, ask for radiology molecular physics, see what their impression is. I mean, all the populations are there, targeting the cell, targeting them as well, what's what test investigation you can use to now to target that system. Case number 12 is another thing from the mandible 44-year-old male being a cyst. So here's the cyst that we're looking at. Okay. It's just at the bottom of the tooth, and you can commonly get cysts or ridiculous cysts, which are basically teeth that have had either root canal or failing with them, or a cavity. And at the bottom of those teeth, you can actually get ridiculous cysts. So it doesn't look too bad, it looks fairly well defined. It even has a border around it. So what they did was they removed the tooth, and they also removed the whole lesion with it. And that became to me. And having a look at it, it looks like there is this space here. It's one where the epithelium looks like the phosphate. This is quite a lot of inflammation. Okay, so far it could be a cyst. But then as you start to look around, then the epithelium starts to get a little bit more busy. And then towards some areas, you see these really inflammatory cells just going off the epithelium into the surrounding walls. One is very large, quite prominently nucleoli. And this is very extending throughout the wall of that cyst. And basically what the show was positive for cytokines, but they show you the extent of the invasion. So here's the potential line. And here you can see how almost massive material, positive material is extending to the wall. This is an example of a primary intraosseous spherical carcinoma. So these can develop in long-standing photonomogenic cyst. And so one keeping that in mind if you see any tibia, photonomogenic cyst, that these are actually canalized. Now the problem right now is that the WHO doesn't really have a category for these, so unfortunately all of these get lumped into T4 because they're intraosseous, but they're actually not that aggressive. So how you write it, of course, is very important in terms of what message you want to convey to your surgeons. I think in most cases, the local excision is fine, you just need to do massive because of big surgery. But most importantly, you need to look at the radiology and come to a fantastic update. Okay. The other thing we need to think about, of course, is the disturbance on carcinoma that might be intraoral, that's of course extending into the jawbones. Could be metastasis to somewhere else as well. So the primary intraocular carcinoma is the diagnosis. So yes, lighting, different case, more sort of calamity, if you like, particularly your medication. So they will send on the urgent topic. Injury to an ulcerated lesion, and this in the left tonsillar area of the aquarium, this is carcinoma. You can see the epithelium here, you can see this quite extensive inflammation. A large number of microbes are still on the epithelial surface. Yeah. And here you can see also the whole stroma is by the sheet of family cells, again highlighting those neutrophils there. And it looks like most of the inflammatory infiltrated is comprising plasma cells. And here's a high power imaging showing you those plasma cells. And some of those plasma cells appear to be extending quite deep, and they also expand as similar collections of plasma cells in the hemodynamic tissue. So there obviously wasn't discriminatory melanoma. I wanted to think about candida. There was no underlying there. To the cat and the patient showed polygonal distribution. But the one thing did show positivity, and this was definitely not happening. It basically showed it from this was the gate of status. And this make me come back in the case of IgG behavior now saying 1 or 2 cases a month. Anytime you see these expensive plasmacytic infiltrating the those biopsies, which are extending deep into the connective tissue surrounding vessels and nerve, think about that. Only 2 or 3 more cases. Case number 14 is from a 14-year-old Nigerian female with a 7-month history of the left-sided neck swelling or discharge. So you can see here, two sort of distinct types of tissue. It looks quite undifferentiated, poorly differentiated, strong, looks quite dense. If it is a node, there's not much nodal tissue left. Again, this tumor is not giving a lot away, perhaps an interval again, a plasmacytoid architecture, maybe interval squamous architecture, but it's pretty much in the small round those kind of category again. And if this wasn't, I did quite a few different stains on it, so cytokine or diffusely positive. P63 also positive, so definitely carcinoma and B40 as well. And then the other thing that lit up in this was this was necessary, this was pharyngeal carcinoma. So looking at the histology of it again, it reminded me very much of a pharyngeal carcinoma with the epithelial islands that were very poorly differentiated, that was surrounded and marked by these lymphocytes. And there was again no previous diagnosis of a known nasopharyngeal carcinoma that was diagnosed after the neck was discovered. Case number 15 is from a 19-year-old male, so not been born at the time. They've got 12-month history and is gradually increasing in size. If you have a look, it looks slightly well-defined. Neck just extending a little bit here. Digestion perhaps extending into a vessel. You can look like most slightly nested appearance in places. Cells like long ovoid, interfering in places, not a lot of stroma between. That hopefully this tumor will be expanding into blood vessels. And also we knew of something living potentially. I did my favorite same comment in which everything as usual, but this was a difficult one because it wasn't really obvious that what it would be. We tried and here at the CD56 were positive locally. All of these are the same for negative. So cytokines are negative, vascular things are negative, melanoma things are negative. And based on the morphology in CD56 data, and then we did RNA sequencing on it, this was diagnosed as LI1B registered medium carbon gain plasmid. And these show this characteristic G and RNA lesions. And it's quite a recently described entity, and what they show is that the family is on one side. Okay. Immunohistochemistry is not the most helpful. Some are positive expression under, some are negative. CD56 is variable. But there are distinct histological features. You get this multi-nodular growth pattern. You get this sort of polarization of vascular networks, the sort of almost vascular invasion or protrusion into vascular spaces. That's quite a common finding. And then you see that sort of nested architecture extending into the blood vessels. And then you're thinking about something like this. And now the emerging evidence right now, we think that this should be thought of as a low grade platform, because initially people thought it might be a benign lesion, but now we can find it to be still learning more and more about it. Case 16 is something a bit different, which we're seeing more and more of, particularly in the UK. So this is a 73-year-old female, showed with a lump in the cup, this white thing that you can see here. Here's a low power image, you can see quite a cystic lesion. And looking at it, you can see quite mucinous and being quite in appearance. It looks like there's some granulation tissue. It was a periphery, but this appears seems all case cellular, we're not seeing any neutrophils or macrophages, things that you would expect to see in extravasation or retention type cyst. This the surrounding granulation tissue, both two sides, about the vessels. But there's not a lot specific. In some areas, there's a thing that these are actually like on crystals. And here again, you can see that the list of crystals have been down. This was an example of for a body of pillar, which was injected in the lid, which is migrated into the ground. And we're seeing more and more of that because pretty much everyone is doing these days, and it's quite common for them to travel in the loose or tissues to unintended sites. So something to be mindful of because they can very much like next recommendation or retention types. Case 17 is infant neuropathy. You can see the background neuropathy tissue and then this not very large tumor, looks very well defined. You got large cystic areas surrounded by quite large oil in the epithelium, but on this side, the epithelium is a bit different. More cystic areas, perhaps in in places. Here again, you can see the vascular appearance, typical, but definitely hyperchromatic media. On the other side, it was quite complicated with some areas of therapy initiation as well. So when we did immunohistochemistry on it, it basically showed that there was more non-cell population here, as long as it was diffusely positive. Almost like improper Roman bridging line pattern in some of these areas, which you saw in the slide like carcinoma early. P63 was quite scattered, but in some areas, P63 was highlighting the border of these islands. You can see quite nicely, particularly the more basaloid areas. And this is the most basic. So anytime I see something which is around 5% or more, I worry about the spine event too. So this is an example of an intraductal carcinoma. This is a high variant, and there's quite a few variants that have been described. So the classic integrated duct line, which looks like surrounding duct carcinoma, but it lacks necrosis, it lacks the invasive elements. But you can get the amplifying or make a hybrid. This one is more like a mixed or hybrid variant. And all of these seem to have some fusion to molecular changes associated with that, but the most sensitive is like the morphological diagnosis in the chemistry can be tested out for this one. And the last case is from 74-year-old patient. The later lesion, here you can see the heart valve bone is the epithelium, and then in between those two you got oxygen. Looks quite intestinal when you look at it, it's got a lot of goblet cells, of the mucous cells in it. But the other areas which have got more acupuncture by some entity as well. But mucous secretion in places that it looks like cells are just floating around in it. Surroundings provides very unique soil places, but in other places it is more dense. And the upper state was met from somewhere like GI or somewhere else, but it was negative from those markers. Okay. And it was followed going to CK7 and 10.2. This was a phenomenon of targeting mucinous carcinoma. And here these are quite a rare, recently described entity. They basically, nothing was referred to the peak is having revolted so far. We don't know a lot about them in terms of how they behave, but they do look very much like a man prominent diet. And they tend to have these characteristics. And ATP1, B7 linkage mutations. But the morphology is quite challenging as well as the immunohistochemistry should be able to come to a definitive diagnosis. Thank you very much. managed to finish in a decent time. Questions, answer this question about any cases. Online material. No question. No question.
What is your experience with endoscopic casting amounts?
Oh,
They're very tricky because
they are very.
all small the class amounts based on the API and the way they are sending everything.
I always take the point of neoplastic carcinoma, that's like the carcinoma extremum, because I want to see a proper area of neoblastoma again. I think the difficulty is how much it appears in a one of the carcinoma. Most neoplasoma can be for plant. To feel mycosis qualified to be in the carcinoma, I think we don't know enough to be honest. I think the guidelines are not great right now. But some of them are really bad for the really logically to show a lot of destruction, but also might not be very actually and take the line from economy. How because most of the class are going to be quite low. But some other borderline can be quite challenging. So yeah, I don't have a definite answer to you. It's basically if you're not sure how much is a advised close watch, you make a life from the hospital. At least locally in terms of the extension, even of time, the hospital requires sympathy. And a lot of time once you respect it, then you will probably have more patient on which you can perhaps think about that. I would hardly ever stick my neck out on biopsy and make a diagnosis because it can be very challenging.
So even if it's seen, it becomes very challenging because there are CTM and it's really have to be but again, I'm lost with the market.
It can, but it's quite bland, so the animal loss from that report very bland by all the things. These are interesting, can it be a neural lesion, I think we should be like doing hospital carcinoma and then we did a mega section and then when was not, he was on holiday in the magic before the mega section and now hoping to find something and found a trying to do medicine and then from the suspicion that it was a really hospital carcinoma, but it can be very challenging. Yeah.
The one thing that you showed Dr. Josh's, rising income.
Yeah.
That was also very tricky, I think, because it had a spending cell morphology. And with this carcinoma, carcinoma, which you take it from that, then I think ultimately it would be the radiology that will be.
Maybe the radiology a little bit, but you won't see so many clear cells, you won't see mucus cells, in a sarcoma, so I think that. So it can be a little bit of a challenge, but things like M1.2, EMA, etc. shouldn't be positive in an SCC, but that could potentially help if you think about it more on the right thing. But in looking at whether we don't want to realize that it's when last perimeter carcinoma, but also players out and in the lifestyle. And as you've seen, the cystic lesion, and as you heard earlier, the most common cerebral malignancy in young patients is a mucoepidermal carcinoma. So if a young patient presents with something like that, either in the jaw or retromolar area, if someone sends you a biopsy says mucosal retromolar area, I promise you it's a mucoepidermal carcinoma, and that's probably the life because that's not a common side for it. So always just have that issue.
So it was very interesting to know that we quite often use 3D 128. So when do we actually use the law?
That's some of the point about 2-3 years ago, because there's some skeletal carcinoma, there's nothing was taken, we were solution of the patient had a various history of SCC, and they've had some radiotherapy or chemotherapy, and then now the recurrence will come back and it looks very initiated, and we just show that it won't be anything else. So we just pulled out some of our cases and noticed that OCD138 very nicely highlights the background epithelium in some of our other work for plasma cell related. We start with the file, of course, it's not really that documented, but in the right context, it can be a brilliant secondary marker. So that's what we particularly for sarcomas, renal, SCCs, is most being developed.
Thank you very much. Thank you all of you for coming, and thank you to our respective speakers who gave excellent talks today. And we are expecting more good talks tomorrow as well. So, all the participants who are here, if you want your certificates, please fill in the feedback forms online, and once you submit the feedback forms, you will get the credit hours accordingly. So, to see you tomorrow at 3:30 and we see for the main session. Thank you.